make it happen. So this was done at SRCC to commemorate the International Childhood Cancer Day. We have continued further. Our faculty, Dr. Ruchira, did the CME in Sholapur, spreading the word that childhood cancer is curable. You can see here, and she addressed the press conference. And these are the challenges which children and the families have spelled out when we sent them the questionnaire. And we are going to highlight and work on it during this year and the next year to find some solution. So just these are the few words about the International Childhood Cancer Day. And now we go on to the subject matter. That is, what are the germ cell tumors? Now, as we know, germ cell tumors are malignant or non-malignant tumors that are comprised mostly of germ cells. And these germ cells are the cells that develop in the embryo and become the cells that make up the reproductive system in males and females. These germ cells follow a midline path through the body after development and descend into the pelvis as ovarian cells or into the scrotal sac as testicular cells. Tumor outside the gonads are also there, which are germ cell tumors, but they are called extragonadal germ cell tumors. And they generally occur along the midline. And I will show you in my next slide as to why they occur in the midline and can be found in the head, chest, abdomen, pelvis, and sacrococcygeal area. As I said before, germ cell tumors are rare, and germ cell tumors account for only about 2 to 4% of all cancers in children and adolescents up to age 20. And this is a diagrammatic representation of how the primordial germ cell tumor, germ cells, they take shape in an embryo. And this is the 3-week-old embryo showing the primordial germ cells in the wall of the yolk sac, as you can see here in figure A, close to the attachment of allantois. And in B, it shows the migration path of primordial germ cells along the wall of the hindgut and the dorsal mesentery into the genital ridge. So this is the pathway which is vulnerable to develop the germ cell tumor during the journey from the initial primordial site to the final destinations. And this is the way why it is in the midline in most of the situations when it is extragonadal. When it is restricted to gonads, it is either ovarian or testicular tumor. But extragonadal can be along this pathway and can occur from head to pelvis. And that is why it is very enigmatic and challenging many a times for the diagnosis. And we have to keep this in mind when nothing fits into the conventional diagnosis in oncology. Now, there is an entity called intratubular germ cell neoplasm. These are considered as a carcinoma in situ phase of germ cell tumor. And this phase precedes all adult cases of, this is more related to adult cases of testicular germ cell tumor. And it is frequently present in retroperitoneal presentation, but rarely in mediastinal presentations for extragonadal germ cell tumor. Cytologically, the ITGCN preceding both seminoma and non-seminoma are identical. So this is a more of a carcinoma in situ, what we call pre-cancerous sort of a thing. Generally, which we are not able to catch them because these are asymptomatic phase. Now, ITGCN can lead to either a seminoma or embryonal carcinoma. And in embryonal carcinoma, if it is an extra-embryonic differentiation, then it is a yolk sac tumor or choriocarcinoma. And if it is an embryonic differentiation, giving all the lineages of a formed embryo, then it results into teratoma. So this is, I am just going to touch upon this thing like a trailer of a movie, and the film will follow my presentation in details for all these aspects. How to move it? So as we just saw that you have a various differentiation, and that can either give rise to seminoma or embryonal carcinoma, which is either yolk sac tumor, choriocarcinoma, or teratoma. And the same is depicted here, that teratomas are tumors which contain cells from the three germ layers, because it is a full embryonal development. So you have a representation of ectoderm, mesoderm, and endoderm. And teratomas can be either malignant or benign, depending on the maturity of these elements. And if there are malignant changes in one of the lineages or one of the layer, then it can be malignant teratoma. Germinomas, they are called dysgerminoma when located in the ovaries, and seminomas when located in the testes. Endodermal sinus tumor or yolk sac tumors are most commonly found in the ovary, testes, and sacrococcygeal areas. While choriocarcinoma, they arise from the cells in the chorion layer of the placenta during pregnancy, which is known as a gestational choriocarcinoma, and non-pregnant child, which is a non-gestational, which represents this chorion layer of the placenta, the chorion layer in the development. Embryonal carcinomas are again one of the types. So you can see that you have a variety of pathology which Dr. Shefali will highlight in her presentation subsequently. So the classification of these tumors in males are basically seminomatous and non-seminomatous. And seminomas are seminomatous germ cell tumors are seminoma or spermatocytic seminomas. And non-seminomatous germ cell tumor are either embryonal carcinoma, yolk sac tumor, choriocarcinoma, teratoma, which can be mature, immature, or with a malignant transformation. While in females, it is endodermal dysgerminoma, which is equivalent of seminoma, and you have variety of other tumors like endodermal sinus tumor, equivalent of yolk sac tumor, embryonal carcinoma, choriocarcinoma, and immature. Generally, in female, you have more of immature teratoma or teratoma with a malignant transformation, mature dermoid cyst with malignant transformation, and there are many other rarer forms, Truma ovarian. I won't go into the detail. I'm sure Dr. Shefali will touch upon this. And what is the cause of germ cell tumor? Not much is known, but we all know one fact, that males with cryptorchidism, that is failure of the testis to descend into the scrotal sac, have an increased risk to develop testicular germ cell tumor. And particularly when it is truly abdominal rather than inguinal. There are certain genetic syndromes which are caused by extra or missing sex chromosomes, and this can make the children vulnerable for germ cell tumor. And this can cause incomplete or abnormal development of the reproductive system and can result into germ cell tumor. The classical examples are like Klinefelter syndromes and many others, which can give rise to germ cell tumor. Now, what are the symptoms of germ cell tumor? We have to be suspicious of germ cell tumor in a young child with a midline swelling or mass that can be felt or seen. As I said, the pathway is along the midline, and that is why any of these midline swellings, which is not fitting with any organ of origin, like when you do the imaging and if there is no epicenter or a main center of which is focused in an organ, and it is a very general tissue level swelling, then one can suspect germ cell tumor, and elevated tumor markers, particularly alpha fetoprotein and beta HCG, can clinch the diagnosis in many of these situations. They can present as constipation, incontinence, and leg weakness. Constipation, if that is in a sacrococcygeal area with compression of the rectum, and incontinence and leg weakness can occur if there is a intraspinal extension compressing these structures. You will be surprised to see that constipation can be so severe. And I remember one case who was taken up for surgery for this symptom. It was almost like an obstipation, but this being a very alpha fetoprotein was done fortunately, and it was very high. And starting with the chemotherapy, these are so highly chemosensitive tumor that it just melted like a wax, and you could avoid colostomy. So one has to remember this diagnosis important. They present very dramatically, but if proven, they can respond also so dramatically, and you can avoid many major surgical procedures or any morbidity. Abdominal pain due to mass, abnormal shape or irregularity in testicular size when it is restricted to testes, and shortness or breath or wheezing if tumors is in the posterior mediastinum in the chest and they are pressing on the lung. There are multiple, like if you have to diagnose, there are multiple imaging studies which Dr. Hiren will highlight, like beginning with a simple thing like ultrasonogram, escalating it to CT scan, MRI, and PET scan. All these modalities can be used to your advantage. And along with images and tumor markers, we can reach diagnosis in many situations. And you may not even need biopsy if it is very characteristics. Genetic studies are always indicated for all these tumors because it tells you many things and helps you in making diagnosis. If it is going to be likely to be bilateral, how whether to preserve the opposite gonad or not, and how one should handle the situations in the management. So genetic studies are important as these tumors are also associated with many of the syndromes. And after you have done the imaging, you have got your diagnosis, the risk stratification is very important to consider for the management. Like low risk are those which are stage 1 testes, stage 1 ovary, and all immature teratoma completely excised. Intermediate risk are stage 2 to 4 of testes, stage 2 and 3 ovary, stage 1 and 2 extragonadal. Extragonadal as such is always, it starts with intermediate and goes to the high risk. It is never low risk. And immature teratoma, which is incompletely excised. While the high risk are stage 4 ovary, stage 3 and 4 extragonadal. As you can see, stage 4 disease in the testes is intermediate. So even the metastatic disease is quite amenable to treatment, and curability is quite high in this group as well. So the low risk is generally managed by, it is not you don't have to do the biopsy if you have a tumor in the ovary or testes which is excisable with a maybe raised, definitely raised markers. You can do ablative or diagnostic surgery, which will give you the final diagnosis also. And depending on the markers which fall after the surgery, either you can observe and monitor, or if they don't normalize as per their fall, which is expected fall, as per the half-life of those markers, chemical markers, then they have to be treated as an intermediate risk. Intermediate risk, again in this group, surgery will be possible because it is not a disseminated. but you have a role of neoadjuvant chemotherapy to decrease the mass, make it more amenable to surgery. And then if there is a complete response, then there is no viable tumor, markers normal, then you can observe. Partial response definitely will require surgery. And if there is a viable tumor, then again post-surgical chemotherapy. If it is a not viable tumor, also many people, many oncologists, they would give at least 1 or 2 cycles as a consolidation following surgery. While non-responder or progressive disease, at the evaluation after 3 cycles of neoadjuvant chemotherapy, we will consider second line chemotherapy and then salvage surgery after that. And that time you will again look at the tumor viability and consider further chemotherapy. Now there are certain very small proportion of tumors which can be refractory to all this conventional treatment, and they will become high risk uh, as such. But in a high risk, otherwise higher stage disease also is a high risk, and that also is following the same principles of neoadjuvant chemotherapy followed by surgery. And if there is a viable tumor and the tumor markers which are raised, then you give post-surgical chemotherapy till you reach marker negativity, and then you consolidate that approach with further chemotherapy. So this is the overall management guidelines, and generally cisplatinum based. And this my colleagues will throw more light on it as to how uh, the whole situation is tackled, and what is the long-term outlook of a child with a germ cell tumor. Generally, the prognosis depends on the extent of the disease, that is the stage of the disease, the size and location of the tumor, gonadal versus extragonadal, presence or absence of metastasis, and the response to therapy in terms of the marker fall, and also histopathology at surgery. The age is also important, and the cutoff age which has been taken internationally is 11 years. And in this pediatric germ cell tumors being rare, they are not part of even SEER data, which is the survivorship data and result analysis done for most of the pediatric solid tumors in USA. So they are not part of that, because even as a nation, well organized pediatric oncology services, they don't have enough numbers. So UK and USA together have analyzed this, and they have developed this cure model in their magic trial, and cutoff death with date which they have taken is less than 11 and more than 11. And as you can see here, the long-term disease-free survival in testicular, ovarian, even stage 4 testicular tumor is in excess of 90%. Till you reach a point where the age is more than 11, so age more than 11, restricted stage will still have a 80 plus survival, while those with higher stage disease and those who are extragonal, last two lines, more than 11 and 11 with extragonadal tumors, they have a less than 70% survival. So as you can see, most of the germ cell tumor you are expecting uh, uh, good survival in more than 80% of the patient. Only very few who require a high chemotherapy and more aggressive approach. So this consortium is going to act now, having defined the risk factor in a prospective manner, to see whether they can downscale the chemotherapy and other approaches for the good and intermediate, low and intermediate risk, and intensify treatment for the high risk to achieve a better survival in that group. So in short, comprehensive management comprises of surgery, chemotherapy. Radiation is not very commonly used because this is not considered as a radiosensitive as much as it is an embryonal tumor as it is chemosensitive. You need to have a supportive care to go with this comprehensive approach. Hormone replacement if required, because if it affects both the gonads and you have to do the hormone replacement for proper growth and development of the child. And very rarely for refractory and recurrent disease, we can consider a more aggressive approach of high dose chemotherapy and hematopoietic stem cell rescue. Continuous follow-up care of surveillance and managing the late effects are very important because it has been shown, at least in adults, that the second malignant neoplasms are very common in this survivors of testicular tumors, testicular germ cell tumors. Almost 50% as the time passes after third and fourth decade, you can have a 50% of them developing second malignant neoplasm. And that is why surveillance and long-term follow-up is very important. And I would just say that as cure rate improves, the quality of life is equally important. And we as a pediatricians basically and a pediatric oncologist as an expert, we don't have to look at a complete cure, not as a freedom from cancer, but we have to look at survival becomes more significant, and complete cure is not just freedom from cancer but balancing act between the risk of treatment modality in hampering the quality of survival and contribution of that treatment modality towards cure. As we depicted earlier, more than three-fourths of the tumors are curable in excess of 80-90%. And there is always a role to decrease the aggressiveness and try to be more gentle and still cure the same number of children. So this balancing act is always there for all of us to follow. Thank you. And I now hand over the presentation to Dr. Hiren, who will tell more about the nitty-gritty of, he is our pediatric radiologist, and he will throw light on imaging modalities, how they are used for diagnosis in germ cell tumor. Dr. Hill.
So, a very good afternoon to all. Am I audible? If yes, please text in the chat box.
Yes, you are audible.
Okay. Thank you so much. So, I myself, Dr. Hiren Panwala, I am a pediatric radiologist working at NHSRC Children's Hospital. So, I'll be talking about imaging and where all locations the germ cell tumor can occur, and what are the classical imaging findings that we see when we are dealing with the germ cell tumors. So we'll start by how we do imaging diagnostic workup for the germ cell tumor. So except for the intracranial germ cell tumor.
ये ट्यूलेटर का नंबर क्या है, कुछ पता है आइडिया? मोबाइल नंबर नहीं, मोबाइल नहीं, यही है क्या?
Okay, yeah. So, except for intracranial, most of the abdominal pelvis tumor initial workup is done by ultrasonography, which is readily available and relatively cheap. And in certain disorders like testicular germ cell tumor, that is the modality of choice. We might not need to some higher modality for diagnosis or detection of the tumor. So, in that, especially in the testicular germ cell tumor, the transsclerotal ultrasound has got 90% sensitivity and specificity. The ultrasound is the initial imaging modality for the abdominal and pelvic germ cell tumor. We also do CT scan whenever we are suspecting the germ cell tumor in the abdomen for the detection and to look for the local as well as distant spread. We use CT chest and abdomen and pelvis for the initial staging of the abdominal germ cell tumor. In a pediatric population, to save radiation, we should use only just a single venous phase. Instead of doing as a triphasic scan, it is not needed for the diagnosis of germ cell tumor that we should do plain scan, arterial, venous, and delayed. That's not needed. So the current imaging recommendation, they encourage us to just to do one single phase venous, which includes the chest, abdomen, and pelvis. That will be sufficient enough to do initial staging for the germ cell tumor. And whenever we are just looking for lung metastasis, then non-contrast CT scan can be done of the chest to look for lung beds. MRI, especially, it is useful whenever we are dealing with the gonadal tumors. In testicular tumor, MRI can be used as an action tool when we are not sure about on ultrasound or we have some sort of clinical dilemma or clinical radiological mismatch. Then we can use MRI. MRI also can be useful in abdominal GCT when the patient has deranged renal profile, we are not able to use the contrast. And sometimes tumor which are having intraspinal extension, we can use MRI as a modality. If you are suspecting brain metastasis, in the case of abdominal GCT, you can do CT or MRI contrast. So these are the imaging guidelines and recommendations. PET scan can be done in initial staging of the germ cell tumor and sometimes on follow-up also. And we use 18-fluorodeoxyglucose positive emission tomography for the initial staging of the GCTs. Now, there are certain scenarios that we might have to do biopsies. So these are some certain clinical scenario where we can do biopsy in the case of suspected germ cell tumor. If the AFP is not elevated and if the neoadjuvant chemotherapy is planned, then before that we should do biopsy. And when the tumor markers are normal and there is a clinical radiological mismatch that we often see in our day-to-day clinical practice, in those kind of scenario, we should never hesitate to do biopsy. We should encourage it. And whenever the tumor is not recommended for upfront dissection or in a testicular tumor in which the high orchidectomy plan, we can do biopsy in those kind of scenarios. So I'll start with the gonadal germ cell tumor, in which first I'll be talking about the ovarian germ cell tumors. So as Dr. Purna ma'am has already described about the classification, I'm not going to detail. I'll be giving you a few radiological pinpoints which will help us to guide what will be the probable etiology underlying the germ cell tumors. So this is the table which shows the different types of the germ cell tumors, mature and immature teratomas, these germinomas, eopsec, and embryocarcinoma. The imaging features I'll be showing with the case example, so I'm not repeating that thing. And of course, you have to correlate with the markers, tumor markers. That also will be taken care of in subsequent lectures, so I'm not going to detail. So this is the classical example how a mature cystic teratoma looks like on imaging. So on the left side, we are seeing the ultrasound image, and on the right side, top and bottom, we are seeing the MRI images. So a mature cystic teratoma, it will have component of fat and calcification, and sometimes they will have component of cartilage or sebaceous material or hair. So that kind of abnormal material give rise to this kind of echogenic material, echogenic solid content inside that cystic lesion. which sometimes it's also known as Rokitansky protuberance. So our role is on USD, first of all, we have to see that whether it's a solid or some sort of complex cystic lesion. And if it is complex cystic, then how much is the thickness of septa? Are there solid areas, or these are just floating echoes that we have to mention it? And on MRI or CT, we can further characterize. In an ovarian tumor, we should encourage to do MRI to save radiation in a pediatric females population. So on MRI, what you will see that the fat is right on T1. So you will see this kind of T1 hyperintensity within the cystic lesion. And the mature cystic teratoma usually are unilocular. Sometimes they can be multilocular, but they are well defined, well marginated, and they can have this kind of ball calcification or fat within that, which gives us a clue that it's looking like mature cystic teratoma. This is another example in which CT scan was done as an unexplained pain in the abdomen. And what we can see is that dense calcification will look like almost a shape of tooth. So this kind of mature calcification, when we see along the walls of the cyst with this kind of fat layer, which is the low attenuation or low density areas on CT, that gives rise, that gives a lot of confidence to us to label it as a mature cystic teratoma. In the contrary, this is the example of immature teratoma. So usually the immature teratoma, they are more larger as compared to the mature cystic teratomas. They have more solid contents. They have more solid enhancing tissues that we can see here. And here the calcification is very bizarre shape, irregular, and they are scattered throughout the mass. It's not like that they will be just seen along the walls of the cyst. The scattered calcification can be seen throughout the mass and a lot of solid areas. So these are the some features in which we can differentiate mature teratoma from the immature teratoma. However, biopsy is mandatory; it's not 100% specific. There's another example of immature variety of teratoma in which you can see large mass with areas of calcification, fat, solid enhancing tissues. And if you see on MRI will have this kind of appearance. The cystic area of the tumor will be having this kind of T2 brightness. And there will be internal septations, and solid area will be slightly iso to hypointense. And on T1 weighted images, if the tumor is having fat or hemorrhage, they will be seen as a hyperintensity that we are seeing here. Now we are moving on to the another aggressive tumor, that is the disc germinoma. So disc germinoma, they are highly cellular tumor, and they are predominantly solid. They are predominantly solid in nature that we can see on ultrasound, and they have this kind of some sort of intratumoral septations. The septations are hypointense on USG, and this septa contains a lot of vascularity. So when you see on CT scan, you will see this kind of lot of internal vascularity which is going across those septas. So when you see this kind of appearance, which is a predominant solid, aggressive looking mass, which has a lot of neovascularity and this kind of fibrous septa, then it might be a disc germinoma. And disc germinoma sometimes can occur bilateral in 10 to 15% of cases, and they can spread to retroperitoneum also. So it is encouraged to do retroperitoneal lymph node dissection when we are planning for surgery. And disc germinoma are associated with the gonadal dysgenesis or the abdominal gonads that contain gonadaloblastoma. Then another variety, that is the yolk sac tumor. So this is the example of yolk sac tumor, in which you can see that a lot of necrosis that is indicated by this kind of hypoattenuating areas within the lesion. The lesion will be markedly enlarged in size, and this kind of tumor, they have associated ascites. They can have intratumoral hemorrhagic areas. So when you see this kind of tumor which is markedly enlarged, areas of necrosis, hemorrhage, and with ascites, then you might think that the patient might be having underlying yolk sac tumor. Then not a germ cell tumor, but this also comes sometimes as a surprise, and the patient present with precocious puberty, and that they can present with elevated estrogen secretions and come with the virilizing symptoms. And this is one of the tumor in which you can see that the appearance of the tumor on MRI is look like more of a sponge-like, like a fluid layering and sponge appearance that is quite specific for this kind of tumor, which is radicular cell tumor. And this tumor has inhibin tumor marker elevation. That is also one of the marker when you do the lab profile. So sponge-like kind of appearance, inhibin elevation, and symptoms related to estrogen secretion, hypersecretions that can lead to that the patient might be underlying granular cell tumor. Now, after covering the important aspect of the ovarian germ cell tumor, I'm moving forward to the testicular germ cell tumor. So, in a pre-pubertal stage, the testicular germ cell tumors are mostly benign, and in which again the mature teratoma, they are the more common one which are seen. But in a post-pubertal age group, if you are finding a tumor in testicle, they have more malignant potential as compared to the pre-pubertal age group. So just to show the demographics and the classification of the germ cell tumor that already has been covered, but just wanted to highlight that the mature cystic teratoma, they are more commonly seen in testis as compared to the other variety. The role of imaging in the testicular tumor is that we already came across that USG and MRI, they are the mainstay. Recently, the contrast enhanced USG also has come up as a promising modality to detect whether we are dealing with the tumor or something benign or malignant. And if we are suspecting malignancy, then we should do initial staging by chest X-ray, CT abdomen, and pelvis. And that is the role of post-operative follow-up to detect the recurrence or to pick up the lesion in contralateral testis or in distant testis. So this is the example of mature cystic teratoma in the testis. So a well-defined mature cystic teratoma will have a well-defined cyst which will have posterior acoustic enhancement. So you are seeing much more brightness posteriorly because of the cystic nature of the lesion. And you are seeing this kind of separation within the cyst. So this looks like more of a mature cystic teratoma. This is the elastography image. So elastography image is one of the technique of advanced imaging technique in which we are measuring the stiffness of the lesion. Cystic teratoma being cystic, it is not going to be a stiff lesion, so that will show as a black color. So when the lesion is more stiffer, it will give rise to more of a greenish or reddish color, and that way we can probably think that this tumor is more cellular or more solid or having more potential towards malignancy as compared to cystic lesions. So in this elastography, what we are seeing here that the tumor doesn't show any kind of color. So that means that it doesn't look like very stiff tumor. So that also gives us assurance that this looks like more of a benign cystic teratoma. Here is an example of a yolk sac tumor. So in which we are seeing that two hypo or two isoechoic lesions with internal vascularity. So in this tumor, we are seeing that the lesions are homogeneous. They don't have calcification. So that is the differentiating point from the teratoma that generally the yolk sac tumor doesn't have calcification. And that is the corresponding CT image showing the enhancing tumor in the left test. Here are a few more examples of a mixed non-seminal germ cell tumor in which the patient also had lung metastasis. We are seeing this kind of peripheral-based nodules. The tumor itself, they are showing well-defined hypoechoic lesions with areas of microcalcification that is seen as a hyperechoic foci. And we also are seeing this kind of enlarged nodes in this patient. This is the role of FDG to do the staging in which we can see that a lot of lung metastases are showing uptake as well as in the retroperitoneum, the enlarged nodes are seen in the para-aortic and the prevertebral location that is showing uptake on FDG imaging. Then one few word about the Sartori cell tumor. So Sartori cell tumor, when they are testicular, they will be seeing this kind of calcified lesion, and that will be showing as a posterior acoustic shadowing, and they will show increased vascularity. So one of the peculiar point of Sartori cell tumor that they might be calcified and they will show increased vascularity. As earlier has been mentioned that gonadoblastoma, they occurs more frequently with the dysgenetic gonads and with a Y chromosome. And the imaging findings are that they are most predominantly solid mass with calcification, and that can be seen on radiographs or CT scan. Now, our other subset of tumor that can occur in the brain are the intracranial germ cell tumor, in which mostly they are in the supratentorial location, in which the pineal region is more common. This is the imaging appearance, and I'll be showing with the example. I'm not going into detail, but usually the germinomas are clear and ill-defined, and they have smaller size as compared to the non-germinomatous germ cell tumor. These germinomas, they have lower ADC values on DWI as compared to the other subset of group. Now, these are the few features of the germinomas. So when germinomas, they are there in the pineal region, they will show engulf calcification that I'll be showing in the image. And in the basal ganglia, they will be, they might or might not have calcification, and they have some sort of cystic changes in the basal ganglia when they present like this way. So, moving on to the pineal region tumors, germ cell tumors, I'll be showing you some representative examples. So, here is the case of pineal germinoma, in which we are seeing that this is the pineal region, which is below the layer of splenium of the corpus callosum. And the lesion is showing this kind of heterogeneous enhancement on post-contrast administration. This is the CT scan in which we can see that the calcification are seen in the central part of the lesion. That is the meaning of engulf calcification. You can see that there is corresponding low ADC values that indicate that it is highly cellular tumor and shows strong restricted. Sometimes the germ cell tumor can occur in pineal as well as supracellular location. So this is termed as bifocal germinoma when you are seeing the supracellular as well as the pineal region. So we should be carefully seeing at the supracellular location also whenever you come across germinoma in the pineal region. And this germinoma has propensity to spread along the ependymal margins. So always look for the metastatic spread across the ventricles and subarachnoid space. This is the other counterpart which can be seen in pediatric age group infancy in children, which is quite aggressive, which is quite larger, and it has more of an infiltrative behavior as compared to the germinoma. And they will show this kind of dispersed calcification as compared to their engulf calcification, what we see in the previous scan of germinoma. So when you see that a tumor which is very aggressive in infancy and children, and you are seeing dispersed calcification, that indicates that the tumor might be having videoblastoma. Now moving on to the cellular and supracellular region tumors. In that, the germinoma, they have T2 hypointensity. Basically, this is the T2 weighted Excel image in which we are seeing hypointense, predominantly solid mass, and that shows heterogeneous enhancement on post-contrast administration. So when you see that lesion, which is T2 hypointense, and shows a lot of areas of SWI glowing. This is the SWI glowing, which may indicate hemorrhage or calcification within the tumor. So that also might be indicating that that a possibility of germ cell tumor needs to be considered in view of highly cellular and restricted, different restricting tumor. That is the post chemotherapy image, which shows a significant resolution of the tumor. Here is the example of craniopharyngioma, just to differentiate that the craniopharyngioma usually in the pediatric age group, they are more of a cystic in nature, and they will have this kind of wall calcification rather than central heterogeneous calcification, which is seen in germinoma. And they will show mainly the peripheral enhancement if only purely cystic or minimal septal enhancement when we see it. Then sometimes, very rarely, a patient might present with a chronic high paresis of the one side and intellectual behavior and a lot of symptoms. And what we will see that patient clinically is fitting like more of a prior sequela of some infarct or ischemic changes. But you will, on a surprise, see that there might be atrophy of the same-sided basal ganglia, and you will be seeing this kind of cystic solid lesion, which shows enhancement. And when you do CT scan in this patient, then you will see hyperdensity within that area. So this is the germinoma in the basal ganglia location, which is also which is not uncommon. We have seen a couple of cases in recent last 2 years. So when you see a lesion in the basal ganglia which shows solid cystic changes calcification, that is the basal ganglia germinoma. The germ cell tumor also can happen in the anterior mediastinum, as we can see here. The fat and calcification are the hallmark features that we can see here on the left side of the anterior mediastinum. And sometimes when the tumor is behaving aggressive in terms of if we are seeing a lot of pericardial effusion, that might indicate rupture of the tumor. And this was the case of immature teratoma, which was showing pericardial effusion and possible rupture into the surrounding spaces. This is the example in which the germ cell tumor occurs in midline in the tail gut and the bottom of the sacrum, in which you will be seeing either cystic or cystic solid lesion involving the sacrococcygeal region, pre-sacral, or sometimes they can have intraspinal extension also. So again, if you are seeing that the child is neonate and you are seeing pre-sacral mass, that comes in a differential of neonatal pelvic mass. And if we shows solid cystic or fat and calcification, that gives us assurance that this might be a sacrococcygeal teratoma. So by this, I have tried to show you the spectrum of germ cell tumors, which can occur in the entire body as well as in the gonads. And these are the peculiar features that we should be looking for. So by that, I would like to conclude today's session. Thank you for attending. Are there any questions? Okay, question we may take later. Thank you. Now I would like to invite Dr. Shefali from Pathology Department.
Good afternoon, everyone. Today I'm going to speak on histopathology of germ cell tumor. I'm Dr. Shefali Jadhav. Me and Dr. Bhuvneshwari Kanalkar are pathologists at SRCC Children's Hospital. So a little bit of intro regarding germ cell tumor. These are derived from primitive germ cells of the embryonic gonad. It accounts for 3.5% of all the pediatric neoplasm. They are broadly classified as seminomatous and non-seminomatous. I'm sorry. Yeah. So this is a wait a second. This is a preview of how a primordial germ cell transforms into a tumoral cell with the additions of genetic polymorphism, alteration of transcriptome with environmental molecules and epigenetic alteration. The germ cells, the primitive germ cells that do not acquire any potential for further differentiation are seminomas and dysgerminoma. The germ cells which are totipotent germ cells are amnional carcinoma, and this undergoes further amnional and somatic differentiation, which forms teratoma. Extra amniotic structures which differentiates towards vitelline structures forms yolk sac tumor, and tumors differentiating towards trophoblast from choriocarcinoma. The epidemiology among children younger than 15 years, it is rare, and in childhood, the majorities of germ cell tumors are present at non-gonadal sites, generally to the sacrococcygeal region, mediastinum or the pineal gland. The common sites for the germ cell tumors. This is a histological classification which was told by ma'am and Dr. Hiren. These are the biological characteristics of the histological germ cell tumor in respect to tumor markers and sensitive to different modality of treatment. So I'll be starting with germ cell tumor of the testis, seminoma. Which requires USG, LDH, AFP, HCG. Serum LDH and plaque may be elevated. HCG is elevated up to 20%, but it is related to the syncytial trophoblastic tissue seen in the tumor. The AFP should not be increased if elevated. Think liver disease or the non-seminomatous component. On gross, as you can see, it is not very cystic. It's a well homogeneous, solid cream and gray tumor. Necrosis and hemorrhage is usually minimal. And in microscopy, you can see these are polygonal cells which have chromatin, and these are separated by dense fibrous septae, which can also be visualized radiologically. And there is a lymphocytic infiltrate present with plasma cells. So it is a peculiar characteristic in seminoma. If 20% of tumors do produce LCG because of the multinucleated sensual trophoblast, which can be seen in the tumor. Okay. So these are the following IHC markers which are positive in seminomas. Spermatocytic seminoma tumor. It is a polymorphic triphasic germ cell neoplasm recapitulating spermatogonia development, and it is unrelated to germ cell neoplasia in situ. It generally derived from post-pubertal type germ cell. It is the rate of genetic mutation increases with age. The peculiar characteristic is not associated with elevated LDH, alpha fetoprotein, or beta SCG. On gross, you can see it is a large tumor, a median size 7 centimeter. It is edematous and mucoid. Necrosis and hemorrhage may or may not be present. And in the microscopy, it has peculiar three types of cell. The small cells, which almost look like lymphocytes, the medium-sized cell, which has a prominent nucleoli, and the large type cell, which is generally accompanied by mucoid leaks. These are the IHC markers which are positive in spermatocytic seminomas. This geminoma, which is an ovarian counterpart of seminoma, it is diagnosed in taking in consideration the patient's age, radiology, and lab values. LDH is 95% elevated. 3 to 5% also shows SCG production, but it is also related to the presence of multinucleated syncytial trophoblast. Hypercalcemia may develop as a paraneoplastic syndrome due to the production of 125 dihydroxyvitamin 3. So on gross, you see it is most of the time it is more than 10 centimeter. It is solid and lobulated, and there are foci of hemorrhage and necrosis with cystic degeneration. One has to look if there are any calcification present, because it may point out to associated component of gonadoblastoma. On this germinoma, it is again similar to seminomas. You can see large cells divided by and fibrous septae along with lymphocytes. These are the following IHC markers which are positive in this germinoma. Embryonal carcinoma, it is diagnosed with USG, serum tumor markers, CT abdomen, and histopathological evaluation is necessary for a definitive diagnosis. Serum tumor markers may not be used as a screening tool. However, elevated SCG, AFP, and LDH may be present. Current guidelines, however, recommend monitoring of these tumor markers before and after initial treatment. As you can see, the tumor is very variegated. It is gray tan in color with hemorrhage and multiple foci of necrosis. And on microscopy, there are three main patterns in solid, glandular, and papillary. These are polygonal cells. These are not generally oval. These are polygonal cells. They are crowded with indistinct cell border and appear to have overlapping nuclei. They are highly pleomorphic with high mitotic figures. These are the positive IHC markers which can be seen in this particular tumor. The York-Sack tumor, which is also called as endodermal sinus tumor, diagnosis microscopy and lab elevated AFP levels are usually diagnostic and are also used for monitoring purpose. So on gross, you can see it is a smooth and glistening surface. It ruptures in 25% of the case. The mean size which it can in diameter, it can be is approximately 15 centimeter. It on cut surface, you can see it is gray, tan, solid, cystic, friable with areas of gelatinous changes. Microscopy, this is very diagnostic of Schiller dual bodies. It looks like glomeruli central blood cells, blood vessels surrounded by epithelial-like cell. And the reticular pattern is the most common pattern seen. These are the Schiller dual bodies, as you can see. This is the reticular pattern, which is commonly seen in this tumor. Mature teratoma. This is the benign germ cell tumor, which is generally seen in pediatric age group. It is mainly diagnosed at USG and also on histological examination. It is a benign tumor. However, there might be a malignant transformation, generally in very old patient. The malignant transformation seen is squamous cell carcinoma, and the prognosis depends on the stage. However, a microscopic focus of immature teratoma does not warrant a diagnosis of immature teratoma and will also not affect prognosis. So on mature teratoma, these are generally cystic, and on on cut surface, you could see there are teeth, cartilage, hair, and sebaceous material. It is less than 10 centimeter, and you can sometimes see the raised protuberance in the cyst, which is called as Rotiansky nodule. On microscopy, it has ectodermal, mesodermal, and endodermal part. Ectodermal, any stratified squamous epithelial; mesodermal, bone, cartilage; endodermal, intestinal or respiratory. A microscopic foci of immature neuroepithelium less than or equal to 4 foci does not warrant again a diagnosis of immature teratoma. This is a Rotilansky nodule, which is a polypoid nodules covered by a squamous epithelium. And you can see here, there is a cartilage, you can see sebaceous gland, you can see adipose tissue, there is a columnar lining epithelial, there are keratin which can be seen in the lumen. This is a dermoid cyst, which are most common type of benign ovarian germ cell tumor, commonly seen in female, more in adults. This is basically, it is a tumor on microscopy. On gross also, you can see hair in it also. But unlike teratomas, you won't see other features. And on microscopy, you can see stratified squamous epithelial and ciliated sulfied columnar epithelial along with keratin and sebaceous gland underlying the epithelium. Immature teratoma. It is a combination of clinical, radiological, and lab finding. It is a rapidly enlarging adnexal mass in a young patient with mildly elevated AFP and of typical radiological features. Requires histological examination basically for grading. So in lab, basically, it has low level of AFP and high level of AFP suggests that there can be a Vyas component. So in immature teratoma, there is hardly any cystic componency, mostly solid and a variegated appearance, a mean size of 16 centimeter. So in immature teratoma, you can see immature neuroepithelium, which can be spindled, rosette form or primitive tubal form. Here, the most important part is grading. The grading is based upon the number of low power microscopic field containing the aggregate amount of immature neuroepithelium. And grade 2 and 3 are considered to be high grade. So whenever you get a case of immature teratoma, always ask for grading. Monodermal teratomas are composed predominantly or solely of one tissue type. There are 3 different types of ovarian monodermal tumors. In stroma ovary, which is a specialized monodermal teratoma predominantly composed of mature thyroid tissue. Ovarian carcinoid tumors and tumors with neural differentiation. Mixed germ cell tumor, a rare type of cancer that is made up of at least 2 different type of germ cell. This may include choriocarcinoma, embryonal, Vyas, teratoma, or seminomas. The tumors are quite rare and seen in 8% of the total germ cell tumor. The most common combination reported is dysgerminoma and endodermal sinus tumor, which is a Vyas. So this is an example of a mixed germ cell tumor where you can see all the 3 components in a testicular germ cell tumor. There's another term called as polyembryoma, which is also a mixed germ tumor with predominant embryoid body, which is a central core of embryonal carcinoma and like cavity and Vyas component. Elements other than embryon body, however, should not constitute less than 10% of the tumor for the term polyembryoma to be used. It resembles an embryonic yolk sac. It behaves like other mixed germ cell tumor. The microscopy, you can see there is an ovarian, there is a stroma, which gives a tumor a lobular architecture. These are the embryoid body. which consist of hyperembryoid disc of embryonal carcinoma. And these are the IHC markers which are positive. Choriocarcinoma is an aggressive form of gestational trophoblastic neoplasia composed of syncytial trophoblast, cytotrophoblast, and intermediate trophoblast. It is generally seen in females, arises from previous pregnancies, more commonly after complete hydatidium from mole. It's an aggressive tumor, and serum serum SCG is a reliable tumor marker. So germinoma, basically the term germinoma often refers to a tumor in the brain that has a histological identical to the other tumors. Intracranial germinoma occurs in 0.7% per million children. This tumor is most commonly seen in hypothalamic hypophyseal regions in the thalamus and the basal ganglia. Serum and spinal tumor markers of AFP and beta SCG are tested. Pure germinomas are not associated with these markers. So this is the microscopy of the germinoma. The cells are uniform in appearance, consisting of large and round cell with vesicular, means at the side, the nuclear, and granular cytoplasm. Gonadoblastoma. Basically, it's a mixed germ cell and a sex-cord stromal tumor. Usually occurs in individuals with abnormal sexual development and indeterminate gonads, usually associated with gonadal dysgenesis with Y chromosome. Y chromosome material appears to participate in this whole gonadoblastoma tumorigenesis. 80% are phenotypic women, 20% are phenotypic men with undescended testes and female internal organ. Chromosomal analysis, hence, is very essential to diagnose this androgen insensitivity, male pseudohermaphroditism, or Turner syndrome. So on gross, 36% is bilateral. This tumor is in a patient with 46XY pure gonadal dysgenesis. You can see the coarsely granular pale surfaces on both the tumor. It is due to this extensive calcification. The primitive germ cell and cord cells are surrounded by ovarian stroma. The tumor cells, as you can see, are surrounded by the ovarian stroma. So this is the sex cord part and this is the germ cell part. And these are the following IHC markers which are positive. So a term called as unclassified mixed germ cell sex cord stromal tumor of the ovary is a rare ovarian neoplasm composed of germ cells and sex cord element, which generally occurs in genetically and phenotypically normal women without the usual histological features, which is usually seen in gonadoblastoma. Very few cases are reported in the literature. The age of presentation is more frequent in girls younger than 10, although it can occur in adult females too. It is associated with isosexual pseudoprecocity. The preferred management is a resection of the gonad that contains the tumor and conservation of the opposite ovarian tube. The histological report shows generally it can be a mixed germ cell, sex cord stromal tumor unclassified along with dysgerminoma and York cell tumor components. Germ cell neoplasia in situ. A little bit about that. It is commonly seen in adult male or even it can be seen in adolescent. Common precursor of type 2 germ cell tumors. It's neoplastic gonocyte-like cells with latent totipotent development located in the spermatogonial niche of seminiferous tubule. It is the precursor for subset of adult germ cell tumors. Associated with uncorrected cryptorchidism, ambiguous genitalia, infertility, and prior history of contralateral postpubertal germ cell tumor. It's present in testicle from a tumor with extragonadal germ cell tumor may present or it can be due to a burnt out germ cell tumor. It is difficult to diagnose in infantile or prepubertal testes due to morphological and histochemical overlap with normal or delayed maturation. This is how it gives rise to malignancies. So this is how the microscopy looks. It is, as you can see at the basement membrane, these are these atypical large cells which are arising from here, and there is no evidence of spermatogenesis in any of these tubules. Thank you. I'll be next, Dr. Chintan, who is a pediatric hemato-oncologist and BMT transplant physician, will be talking on ovarian management.
Good afternoon, everyone. I hope my slides are visible, and I definitely thank my previous speakers who have set the tone so that my job is easy. And my main part is mainly diagnosis and management. I will just briefly touch upon the just a small kind of revision for ovarian germ cell tumor, which Madam Hiren and Shefali has already touched upon. So as we know that 2 to 3% of ovarian carcinoma in Western countries and up to 15% in Asians and Black women, then peak incidence is usually in adults with PE or is early 20s. And Asian and Blacks are more than Western countries and white women. And this is a stage-wise distribution what we see. Mostly they are unilateral, but bilateral ovarian cancers are also common in dysgerminoma and mature cystic teratoma is one of them. Now, this classification, which we have already learned in both the talks, just wanted to highlight about because we have learned everything together. Just wanted to highlight about ovarian part that what are the types of ovarian, different types of ovarian germ cell tumor. The commonest are the either yolk sac or dysgerminoma or endodermal cymal tumor or sinus tumor or embryonal carcinoma and the immature teratoma. Along with that, some other variants are mature dermolysis with malignant transformation, monodermal and highly specialized stromal ovary, carcinoid, stroma ovary with carcinoid, others in mixed forms. So, if we just broadly want to remember the ovarian germ cell tumor types, probably the embryonal, endodermal, dysgerminoma, choriocarcinoma, immature teratoma, these are maybe few of them to remember. Now, going on further. Now, if as a general surgeon or general practitioners, we wanted to learn how many percentage of ovarian masses can be malignant starting from infancy, excluding the neonatal age, up to the adult age. So these are some of the studies which have highlighted, and if you can see the combined data out of 244 patients of various studies, 20% are malignant. So this is also another important thing to remember that all ovarian masses are not malignant tumors. They are not cancers. So some of them are non-malignant, majority of them are non-malignant, and these are just a brief of that. Where does this tumor spread, particularly when the ovarian tumors are concerned? They spread nearby to the lymph nodes, they spread into the peritoneal surface, and they spread to other pelvic organs, other abdominal organs, and distant spread like lung, liver, brain in choriocarcinoma particularly. Now, what is the presentation? So usual presentation is with abdominal pain due to rapid growth in germ cell tumor and stretching of ovarian capsule, abdominal distension, pelvic fullness, urinary symptoms. Some patients may present as an acute abdomen due to hemorrhage or torsion of the mass, ovarian mass, or rupture of the ovarian mass. And sometimes you can feel the palpable adnexal mass also. The ovary is most common site of germ cell tumor after infancy. Pain and palpable mass is seen in majority of the patient, lower abdominal fullness, obstruction, and less commonly the acute abdomen, which is 10% from the torsion or tumor rupture. Tumor dissemination occurs by local extension, intracavitary seeding, or hematogenous spread. Intracavitary seeding may involve the surrounding pelvic organs like omentum, bowel, spleen, diaphragm, or other pelvic organs, and rarely the bone or brain involvement can happen like in choriocarcinoma. Staging workup we always see it's CT scan and PET scan. But before going for the staging workup, we need to do some diagnostic tests. And the most important test, as has been highlighted in the previous talks, are the tumor markers. And this is just a brief of the tumor marker. That if you are having high AFP, it will be endodermal sinus tumor. If you are having both high AFP and beta HCG, it will be embryonal carcinoma. If you are having marked elevation of beta HCG alone, it will be choriocarcinoma. If you are having normal markers but AFP may be elevated, it will be pure immature teratoma. And if you are having all the markers normal, it will be mature cystic teratoma. Another important fact which is wanted to highlight in my presentation is that some of these tumors are associated with high thyroid markers like T3 and T4 is elevated, particularly in the choriocarcinoma, because the homology of beta HCG and thyroid stimulating hormone, and also mature cystic teratoma due to secretion of thyroxine by mature thyroid tissue. So elevation of thyroid hormone can also be present in some of the ovarian cancer. Staging workup is CT, chest and abdomen and pelvis. And nowadays PET scan is more reliable for all solid tumor malignancies. But before staging, the most important diagnostic test is, as I have said, it is tumor marker. As I have told you that what baseline tumor marker will be elevated in which type of ovarian cancer. I am just highlighting some slides on these important tumor markers. Like in AFP usually indicates the presence of malignant components. So if AFP is raised, it may not be the teratoma. It can be a yolk sac tumor or embryonal carcinoma. See, a half-life of AFP is 5 to 7 days, and it reaches peak concentration at 13th week of gestation, and gradually it falls to reach to adult value less than 10 by infants by 1 year of age. So beyond 1 year of age, if you are having more than 10, or if you are having anything more than a normogram, it will be an abnormal alpha fetoprotein. Important thing also to remember that abnormal alpha fetoprotein can also be raised in hepatoblastoma, which is one of the commonest pediatric liver tumor, pancreatic malignancies, and gastrointestinal malignancies, as well as lung cancers, which we do not see commonly in the pediatric population, but yes, it can be elevated in these 4 situations also. Ratio of concovalant A to non-bound AFP can be useful in discriminating the AFP rising from the ovarian mass versus the liver production. Then second important part is beta HCG. It is elevated predominantly in dysgerminoma. Other condition also associated with beta HCG is multiple myeloma, liver malignancies, pancreas malignancy, GI tract malignancy, breast, lung and bladder malignancies, and occasional hormonal manifestation. The half-life is 24 to 36 hours. So predominantly embryonal carcinoma. Then the most non-specific marker but very important in ovarian germ cell tumor is LDH. If LDH is elevated, it predominantly suggests non-yolk sac, non-embryonal tumor like a dysgerminoma. Partial alkaline phosphatase, also PLAP, which we found, it's also important in stage 1 dysgerminoma, and is almost present in 100% of cases with the advanced tumor. So the LDH and PLAP is also important marker. And the least important marker, but sometimes commonly done when we see as a pediatric cancer specialist, because ovarian cancer may not be as common as the ovarian malignancies, ovarian carcinomas, which adult oncologists see, and they mostly do CA125 and CA19-9. Now, the role of CA125 and CA19-9 is limited in pediatric germ cell tumor. So that is a message that rather than jumping to CA125 or CA19-9, we should be doing AFP, beta HCG and LDH more commonly, even if it is the problem comes when the medical oncologist sees the patient. So there, these tumors are more common, and then they do these tests, and then they are sometimes elevated, and the entire diagnostic prototype changes. So that is important thing, that these are the things which usually we do not do in pediatric ovarian germ cell tumor until unless your all markers are negative and your histopathology is favoring something non-germ cell tumor like an epithelial cancer. In that case, CA125 may be useful. This is a bit of hazy slide, but I just wanted to briefly touch upon the staging workup. Stage 1 is limited to ovary. Stage 1 has another 3 parts, A, B, and C. A is limited to ovary, but limited to 1 ovary. A1B is limited to 2 ovaries, but when it goes to part C, it is always a rupture of capsule or superficial seeding. The tumor comes under the surface. This is called part C of all the stages. Stage 2 means limited to the ovary and confined to the pelvic organs without beyond pelvic organs. 1 is same, 2A is 2B is same like what is in 1A and 1B. But here 2C is when it again comes to the surface or peritoneal washing is positive or ascites is present with malignant cells. Stage 3 means it is involving beyond the pelvic organs. It involves the omentum, bowel, as these are the common part. And again, there are 3A, 3B, and 3C. In 3A, usually you see the peritoneal washing being positive, but nodes are negative. In 3B, you see the washings are positive, and it is exceeding that implant, what we call the peritoneal seeding, is exceeding less than 2 centimeter. And if it is more than 2 centimeter, it is stage 3C with or without low nodes involvement. and the 4 is always a distant spread, either to bone or to liver or to brain. These are the called stage 4. So the basic thing, it starts with surgery, and we have an expert, experienced and well-known surgeon with us. So I don't want to highlight much on surgery, but sir will highlight, Dr. Rasik will highlight about the surgical part. But yes, surgery, majority of the cases, like Dr. Purna has said, it follows the post-operative chemotherapy. Now, what post-operative chemotherapy, or let us say neoadjuvant chemotherapy, means before surgery begins, is mainly a cisplatin-based chemotherapy. And the importance of cisplatin here is that no protocol in the earlier time was without cisplatin. In spite of knowing that cisplatin is a toxic chemotherapy, particularly for the genitourinary organs or the auditory things, but this tumor is one of the most sensitive cisplatin tumor, sensitive to cisplatin, and that's why cisplatin plays a major role. Different doses have been tried: high dose cisplatin versus low dose cisplatin, 40 milligram versus 20 milligram. In spite of having the toxicities, cisplatin is still the backbone of the tumor treatment. Now there are intergroup trials are available, pan Europe and pan America. And what does these trials say is, look at the overall survival, and that is why the importance of pediatric malignancies being treated in a right way, with right setup, with right people, is important. That even if you are dealing with stage 4 cancer, which is completely a gone case in adult world, we have a survival up to 80% or 90%, at least overall survival. So the ovarian cancer, ovarian germ cell tumor, no matter whatever the stage is, the treatment has to be offered, and with a curative intent, not with a palliative intent, with a curative intent. The regimen may differ, but the course has to be completed based on your staging and risk stratification. So, low risk tumor like stage 1 ovary, the surgery alone may be helpful, but in intermediate risk and high risk tumor, the surgery has to follow by chemotherapy. Whether 3 cycles or 4 cycles, it depends on what risk categories you are falling in. Now, when the cisplatin-based chemotherapy and the other part of the world, which is Europe, where the carboplatin chemotherapy were tried, then in this particular tumor, I think the world has decided to come together. And in fall of 2009, there was a memorandum of understanding between various countries, and particularly, I'm very happy to share that India plays a major role in making the guidelines of a germ cell tumor. And because particularly the Bombay and Tata Memorial Hospital and a lot of other centers has a huge number of germ cell tumor patients. So in this trial, they had to put India on their map, and India was very well part of the latest trial for the last 5 years or 10 years, which is going on, which is MAGIC trial. More than 1,000 patients, because majority of the patients they get from us. The protocol is same, cisplatin or carboplatin based, and the outcomes are similar whether you use cisplatin or carboplatin based protocol. And they keep on doing the biannual meeting to understand what is best for our patients. And this was a 25 years experience which was published in the JCO in 2015. And if you can see, that various UK and US trials have tried different regimens, PEG or JEF, means cisplatin or carboplatin based regimen, every 21 days. Some has given 2 cycles, some has given 4 cycles, some has given 3 cycles, depend on what risk stratification you are following. But the norm is minimum 2 cycles up to 4 cycles, and in some you may need 6 cycles, but predominantly 2 to 4 cycles is the regimen usually we need. So what this trial has given to us, they have risk stratified further the intermediate risk germ cell tumor particularly, and they have divided intermediate risk germ cell tumor into further 3 categories based on the age. Most important, 10 years, less than 10 years, more than 10 years, and in less than 10 years, what is the stage 2 to 4, and in more than 10 years, so there are 3 risk stratification, particularly intermediate risk there are 2, and then the last one is poor risk. So they have further defined the intermediate risk category, because everyone is clear about low risk and high risk, but what is the intermediate risk treatment strategies there they have decided based on the age. So 10 years is very important. Now, what regimen they have followed. So they have followed 4 type of regimen: CEB, PEB, BEC, BEP. What is CEB and what is PEB? So base CEB is a carboplatin base, PEB is a cisplatin base, and the dose here are less because it's less than 10-year-old with somehow better prognosis compared to more than 10-year-old. And the BEC is again same carboplatin base versus BEP, which is cisplatin base. So what is the difference between these 4 regimen? If you can see this chart, that CEB and BEP, PEB, sorry, and BEC and BEP, the difference is mainly the cycles. In the first 2, there are 4 cycles. In the last 2, there are 3 cycles. And if you can see what is another difference is that the omission of those day 8 and day 15. So in the BEC and BEP regimen, which is standard risk arm 2, which is more than 10 years of age, they are included day 8 and day 15 cisplatin, probably adding more cisplatin dose, but worth by adding because the outcomes may be benefited with adding of more cisplatin in the regimen, versus standard risk arm 1, which is less than 10-year-old, where they have omitted day 8 and day 15 bleomycin and kept the cisplatin dose up to 20 milligram per meter square. So the two difference in these cisplatin versus 20 versus 40 and the bleomycin day 8 and day 15 addition in this regimen. Stage 1 managed with surgery alone, excellent survival, and that's important message, and the surgical part Dr. Rasik will explain in detail. Stage 2 and beyond, the chemotherapy plays an important role, which I have explained you in the various regimen. If the chemotherapy fails, and that is why I say that even in the stage 4, the outcome is more than 80%, because we have a very good second line and third line agent, like ifosfamide, cisplatin, and paclitaxel based chemotherapy, which is TIP, or ifosfamide, vinblastine, and cisplatin based chemotherapy, which is VIP, or gemcitabine and oxaliplatin based chemotherapy, which is GEMOX. So, in spite of your first line treatment phase, we still have an options to offer the second line chemotherapy to our patients. The last slide about the principles of surgery, I just don't want to go in much detail because I will explain, but just important thing is that to avoid the tumor spill, collect ascites peritoneal washing, examine peritoneal surface because your staging depends on that, as I have explained you. Unilateral oophorectomy, examine contralateral ovary, biopsy if suspicion lesion, examine omentum and remove if adherent or involved, and inspection of retroperitoneal lymph node. Sampling is important, dissection may not be always needed. I will end here and I will invite next speaker, Dr. Ruchira. She'll be just coming in 1 minute. She's going to speak on on testicular germ cell tumor diagnosis and management. Thank you.
Good afternoon, everyone. Sorry for the slight delay. After Dr. Chintan's talk about ovarian germ cell tumors, I go on to the next organ, which is the testes, and we'll talk about the testicular germ cell tumors as well. Before we talk about the abnormal, we also need to know about the normal. And we all know that the testes and the development of the testes actually starts from about 2 to 3 weeks, where the first primitive germ cell tumors actually start forming. And then from here, they start a migration process before they actually reach their final position in the testicular area, in the scrotum. And so therefore, when we talk about germ cell tumors, you may actually find them all along that tract of migration as well. And we don't find just gonadal tumors, we also find the extragonadal tumors. So therefore, germ cell tumors in pediatrics become something which is not restricted to the gonads, but otherwhere also. So like what Dr. Chintan mentioned, that the germ cell tumors in pediatrics is rare. Similarly, testicular tumors are also quite rare, but we have what is called a bimodal peak. We often see the tumors coming in very young children around 2 to 3 years of age, and then in the adolescent and the young adult population as well. Interestingly, the highest incidence of testicular tumors is actually from Denmark and Norway. And these may be also associated with what is called a testicular degenesis syndrome, where these germ cell tumors are associated with cryptorchidism, hypospadias, and decreased fertility as well. It is believed that the in utero exposure to endocrine disruption chemicals like insecticides and pesticides may have some role to play in the development of germ cell tumors. However, it has not been corroborated very well. And in terms of genetics, some families seem to be more affected than others. And whenever there is a family there which is affected, or when you have a person who's affected, it's usually not the parent or the children who are affected. You have to screen the brothers in this, because there's a relatively high risk in brothers to get tumors if there is a genetic predisposition as well. They haven't identified one particular penetrant gene, but they found that there may be some defects in the repair mechanism in just about 10% of the tumors. And CHEK2 is a potential gene variant that has been implicated with testicular tumors as well. We can also detect these tumors intranatally or prenatally as well. And when you are looking at something that's congenital, then the tumor that you think of is juvenile granulosa cell tumors. Usually the left testes is more affected, and some of these kids may also have ambiguous genitalia and these present in this. Now, when we're talking about germ cell tumors, we know that they may not just be germ cell itself. So any testicular tumor may not be just germ cell. Like Dr. Chintan mentioned, some of them may be benign. But when you're looking at malignant conditions, then some of them may also be rhabdomyosarcomas or other testicular tumors as well. But within the germ cell tumor itself, most of them are endodermal sinus tumors, which Shefali has already described. A few of them will be mixed. Then will be teratomas, seminomas, teratocarcinomas, and embryonal carcinomas make up the rest of the group as well. So what is the pathogenesis behind this? When we classify germ cell tumors, the WHO has now classified them as germ cell neoplasia in situ related testicular tumors, or those that are not related to the GCNI, so germ cell neoplasia in situ. Usually the pre-pubertal ones are the ones that are non-GNSIs related, and they, because of loss of their rungs and its tumor suppressor genes, some chromosomal abnormalities associated with DMRP1 protein, or maybe unknown factors, they then kind of get predisposed to develop the subtypes of these germ cell tumors, which are seen in the pre-pubertal age group. However, the GCNS related tumors, when the child achieves puberty, then the kind of germs, the mutation kicks in, and usually it is always associated with changes on the 12th chromosome, and therefore because of these changes, the patient then develops either a seminoma, an embryonal carcinoma, or choriocarcinoma and other tumors as well. So there is always some second hit that is going to be present as well. I know that Shefali has gone through most of these tumors with us, but just the kind of salient features of all of them, especially the prepubertal ones. The yolk sac prepubertal one, also called the endodermal sinus tumor, is the commonest germ cell tumor that we see in children under 2 years of age. And usually we see it as a pure yolk sac tumor, not a mixed yolk sac tumor. And the way we will define this or diagnose this is that you can do a blood test and an elevated AFP will be present in almost 95 to 98% of these cases. Ultrasound findings have already been described by the Hiren, but just as a classical thing, this is large, round, ovoid, hypoechoic masses, but they may also be hypervascular as well. Then we come to the teratomas, again the prepubertal non-GNIS ones. The most common testicular tumor will be a teratoma. While teratomas generally derive from all the 3 germ cell layers, they usually don't have a lot of significant cellular atopia and usually do not metastasize anywhere. And these can then be divided into mature and immature forms. On ultrasound, they are usually heterogeneous masses, well defined. They may have single or multiple septae that are present. And depending on which of the germ cell layers is more prominent, there will different complex architectures may be found in these patients as well. We know that teratomas have a lot of other things like cartilage, fibrosis, calcifications that may be present. And mature teratomas can also be cystic with a lot of fat content in them, whereas immature teratomas are usually encapsulated but have neuroectodermal components attached to it. When you look at vascularization, the teratomas are usually poorly or mildly vascularized as compared to the endodermal sinus tumors in these patients. And dermoid and epidermoid cysts are also part of the prepubertal teratomas that we see. When we move towards the GNIS, the more like the post-pubertal, they usually precursors of malignant germ cell tumors and usually found rarely in children, but if found with children, they're usually associated with cryptorchidism and gonadal dysgenesis as well. Then there is when we talk about these, the germ cell tumors, the ones that we know of are seminomas. We know that seminomas generally arise from the germline epithelium of the seminiferous tubules. They usually contain syncytial trophoblasts. They round, homogeneous hyperechoic lesions can be lobulated or multinodular, but don't have calcifications or cystic areas, and usually not very vascular, but peripheral vascularization may be there. With embryonal carcinomas, which arise from the primitive anaplastic tumor cells, they are very small in size, but invade the tunica albuginea, usually poorly circumflexed, and they may show necrosis in them. Choriocarcinomas, like Chintan mentioned as well, are generally we detect them when we find high beta HCG levels because they're arising from the malignant trophoblastic and the syncytial trophoblastic cells both. And these are the ones that can metastasize to different areas like the lung, liver, brain, or the GI tract as well. Similarly, mixed germ cell tumors are also common, and these could be usually more seen in pubertal males. There is also an entity called regressed germ cell tumors, which is rare in children but known to occur, and they are also called burnt out germ cell tumors, which generally happens because a very rapidly growing germ cell tumor outgrows its vascular supply and therefore starts to atrophy or burn out, as the term itself suggests. Usually, these tumors will be seminomas or choriocarcinomas. There are non-germ cell tumors as well, like the sex-stromal tumors, the Leydig tumors, the Sertoli cells, or the juvenile granulosa cells. But since they're not a part of our talk today, I will not go into details of these. And then there are tumors that contain both the germ cell and the sex-stromal cells, which are gonadoblastomas, usually found with undescended testes or gonadal dysgenesis. Again, I will not go into these. So how do you, what do you need to do with them? You have to do a thorough history and a physical examination because most of them will be a painless testicular mass. We all know that anything that's painful is usually not malignant. Hence, a painless testicular enlargement is what is common. It's often picked up when you have trauma or when the child notices that there may be a persistent swelling. It's often thought of to be a hydrocele first or a hernia, and bruising is less common findings that are associated. When you look at examination, they're usually firm, they're non-testicular masses that you actually pick up as well. Your differentials could be a testicular torsion where the pain has gone away because now the testis is dead, or has lost its vascular supply completely. It could be a hernia, hydrocele, epididymitis, or paratesticular mass as well, and those you have to look at them as your differential. Please remember that you have to evaluate all nodes, and the abdomen should also be carefully palpated because there may be a metastasis or a mass that may be present in the abdomen as well. How do you stage them? The classical staging or the COG staging, the Children's Oncology Group of staging is very simple. You stage them grade 1 to stage 1 to stage 4. Stage 1 being limited to the testes. Usually you do a high inguinal orchidectomy, and stage 4 is distant metastasis, usually what we find with choriocarcinomas. There are other classifications that are also available, like the AGCC classification, which is a little more detailed, and which also looks as the serum tumor markers for the non-seminomatous GCTs to grade them and classify them based on how high your LDH, your beta HCG, or your AFP is. And then there's also our MAGIC consortium, the Malignant Germ Cell International Consortium criteria as well, which grades them into low standard, standard 1 and standard 2, or poor risk groups in these cases. And MAGIC trial is the only one which uses age in years as a risk stratification criteria as well. How do we treat them? Usually a good physical examination, ultrasound imaging tends to add an MRI if required, will kind of guide you whether you think this is malignant or benign. If you think that this is benign and you have normal tumor markers, benign characteristics on ultrasound, and you think a good surgery is possible, then you look at doing a testis sparing surgery in these patients. However, if there's any suggestion that it is malignant, you should look at a radical inguinal orchidectomy in these patients. Sir will actually talk about surgery in these patients, so I really won't go into them. But what I want to talk about is the different criteria. So if you have a seminoma stage 1, then usually we will either do surveillance after surgery or follow up with just one cycle of carboplatin and F with them. But if it's a stage 2A, we offer them BEP or EP, the details of which Chintan has already talked about. We usually tend to give 3 to 4 cycles with them. Radiation is reserved for very few cases. And stage 2B or 3, we offer 3 to 4 cycles of BEP in these patients. If they continue to have PET positivity, then you do a repeat resection for these patients. For the non-seminomatous conditions, the low risk, generally surgery is what is often put. You may choose to give one cycle of BEP in these patients. These are the European guidelines that are being discussed over here. Therefore, BEP is the choice that we are giving them. In the stage 2B or the stage 3, we may either choose to give 3 to 4 cycles. Generally, 4 cycles is what is preferred. Now, a lot of pediatric trials have worked to show, and pediatric results are very good with germ cell tumors. So different categories, I'll just go through a few of them. The first one was the POG or the Children's Cancer Group CCG trials, which ran from 1990 to 1996. What they actually showed was stage 1 and stage 2 or low-risk germ cell tumors could be treated by surgery alone. Or they also thought if there was stage 2, you could give them chemotherapy as well. And that they had very good survival rates, where an event-free survival rate was 78.5%, but overall survivals were 100%. Please remember, in pediatrics, we always talk about overall survivals, which means the chance of living your normal destined life that you have with these patients. And this could be achieved with just surgery alone. Those who did relapse could be given chemotherapy, and further surgical excision could be done with them. The combination chemotherapy which was used at that time was PEB with a smaller dose of bleomycin in these patients. This was followed by the next trial, which was used for the higher group, which is stage 3 and stage 4 high-risk GCTs. But even in those cases, they gave you an event-free survival of 94% and again an overall survival, which was still 100% for these patients. We did realize that there was higher toxicity that was present when we gave high doses of cisplatin, etoposide, and bleomycin, but the overall survival still remained very good. Chintan talked about the AGCT 0132 trial, which ran from 2003 to 2011. This did not have very good results with the intermediate risk group. That's where we thought the 3 cycles was less, because now we started trying to look at whether we could reduce the number of cycles that we were offering these kids. But even then, for the other risk groups, our event-free survivals was still very good. The AGCT O1P1 was a trial, which was like a pilot trial that was run from 2004 to 2007, looking at for high-risk patients where they thought maybe cyclophosphamide is being added to the classical PEB regimen, then it would be better. The 4-year results show the event-free survival was 74% and overall survival was 89%, which is not very different from the existing trials and what they were already showing to us. Therefore, cyclophosphamide has not been added in subsequent trials as well. We all talk about the MAGIC trial. The best thing about MAGIC trial was to compare the results of cisplatin versus carboplatin and look at how we could reduce the toxicity that we associate with cisplatin. And they found that both cisplatin and carboplatin had very good survivals in the tune of about 86%. So you could use either of these 2 regimens depending on what your unit actually preferred. So to conclude, I just have a 1-minute review. What you need to really remember about testicular germ cell tumors. If you ever think about one, so pre-op stage, obtain a serum alpha fetoprotein and a beta HCG and ask for a CECT chest and abdomen, because then you're looking at staging also at the same time. Surgery has to be a radical oppidectomy with control of the cord structures at the internal ring, and you deliver the testicle via the inguinal incision, not a scrotal incision. A high ligation of the cord structures at the internal ring, and please avoid capsule disruption in these patients. If your tumor markers are negative, then you could look at testicular sparing approaches as then. Don't forget the lymph nodes. But remember, if your radiology says that the retroperitoneal lesions are less than 1 centimeter, then they may not be involved. 1 to 2 centimeters, usually we say assess after 6 weeks of surgery, but if they're still present, you have to think that they are definitely diseased, and anything that's more than 2 centimeters is definitely diseased. If you're looking at children who are less than 11 years of age, we look at looking at the abnormal retroperitoneal lymph nodes, but then RP-LND should be done for boys who are more than 11 years because they are there. What not to do is something that is more important than what to do. What not to do is please avoid transscrotal biopsies or capsule violations, because at the moment you do a transscrotal biopsy or use a scrotal approach to do a oppidectomy, we upstage the disease. Even though it's a stage 1, we will now call it a stage 2, stage 3. So if a scrotal biopsy is done, we call it stage 2. Therefore, we'll have to do a radical oppidectomy, or else a hemiscrotectomy will also need to be planned for in those cases. You have to look at both pediatric and adult staging, because you need to look at both prepubertal and adult, so you can't forget either of them. Enucleation with frozen section can be actually done to look at mature teratomas, because in those cases, you may not need an oppidectomy. Now, everyone, whenever they think of cancers, they think about chemotherapy. However, ports are usually not mandated, because if it is a standard or a low risk, then maybe 1 or 2 cycles is needed. So the discretion of the physician, you'll have to talk to us before you do the surgery as well. And please remember, metal clips are not to be used, because if needed, we may be going in for radiotherapy for these patients, and that may be a deterrent for all of us. Remember, doing what is best for the children is more important than doing what we think best. And therefore, these approaches will always kind of hold good for us. Dr. Rasik Shah is an expert in pediatric cancers and oncosurgeries, and his opinion really matters. So with surgery, take a consult for him. With chemotherapy, doing a good tumor board discussion for these patients will actually be worthwhile for these patients. I'll finish my session with that, and I hand over to Dr. Kriti after this, who will speak on the extragonadal germ cell tumors, which means tumors that are beyond the normal gonadal areas that are present. Thank you so much for your patient hearing.
Thank you, Dr. Ruchira, for handing over. So I'll be talking about non-gonadal GCTs, basically the atoll of germ cell tumors. So all the previous speakers have gone through quite nicely and explained everything in great detail. I would take about 20 minutes to talk about the other sites where GCTs can be seen. Once I figure out how to bring that up. So I'm Dr. Kriti Hegde, and I'm a pediatric hematologist and oncologist at SRCC Hospital with special interest in solid tumors and brain tumors. So we've learned about the testicular and the ovarian GCTs. Where else can GCTs occur? So like Dr. Ruchira, Dr. Purna, Dr. Chintan have all spoken about how these germ cells migrate. So anywhere along their migration, if there are mutations that occur, it can lead to GCTs over there. Now, any extragonadal GCT is comparable to a gonadal GCT. They're morphologically, immunophenotypically homologs of gonadal GCTs. Now, the picture that you see on the right, what it basically is meant to show is that each of the histological subtypes of germ cell tumor actually mimics the remnants, the fetal and other embryonic remnants. So a germinoma actually resembles the primordial germ cells in the fetus. When it is in the testes, it is called seminoma. When it is in the ovaries, it's dysgerminoma. And in the brain, it is then called as a germinoma. The teratomas mimics the fetus itself. The yolk sac tumor resembles the yolk sac. Choriocarcinoma resembles your trophoblast or the placenta. And the embryonal carcinoma is composed of immature embryonic tissues. Now, there is persistent uncertainty regarding the nature of cell of origin and also its place in tumorigenesis. Dr. Priti will be actually talking in great detail about the sacrococcygeal teratomas. That is one of the commonest site in infancies, and it is often detected in utero with prenatal ultrasound. The other commonest site, well, common in the sense that after the gonads and sacrococcygeal teratoma, the other site is the mediastinal GCTs, which represents about 5% of all the germ cell tumors that you see in children and 12% of all the mediastinal tumors. They're mostly located in the anterior mediastinum. So if you go to take a lateral X-ray and see where it is, if it's in the anterior mediastinum, then one of the differential would be a germ cell tumor. Occasionally, you can also see it within the pericardium. 2/3 of the mediastinal germ cell tumors are almost always teratomas. Survival in a mediastinal germ cell tumor is slightly poorer as compared to gonadal GCTs. As you would have seen, the previous speakers have spoken in the tune of 93, 95%. 70% is good enough, but when you compare it to those tumors, it's probably slightly poorer. Now, as physicians, as surgeons, when you see a mediastinal mass, it is absolutely essential to remember that there is an anesthetic risk. Now, when you see a huge mass in your imaging, there is an itch to do something about it, whether it is a biopsy or whether it is to make the child lie flat to do a CT scan. So this was a paper that was published quite early by Schamberger et al. That reviewed, that actually did a prospective study where they evaluated the CT and the pulmonary function tests of children with mediastinal masses. So the inference of the study was that if your tracheal cross-sectional area and your peak expiratory flow rate was more than 50%, only then in that case a child is fit for a GA or sedation. So it's absolutely essential that before you sedate a child with a mediastinal mass or make them lie flat, you have to consider that it could be life-threatening. Retroperitoneum is another site, even lesser common. So 4% of all the germ cell tumors, half of them occur quite early in life, in the first year of life, and 73% of them occur before the age of 5. It is this germ cell tumor where there is a female preponderance, whereas all the other germ cell tumors, there is somehow more male predominance. Now, majority again of the retroperitoneal tumors could be teratomas. 4% of them would be malignant tumors. Now, because given its location and the ability to grow in this space quite unhampered, if this is a malignant tumor, they generally come at an advanced stage of presentation. Now, all of us have spoken about this great consortium that was formed, that is the MAGIC trial, which tried to, so germ cell tumors, although you do see in children, it is not one of the commonest tumors that you see in children. So it was important to bring the whole world together so that we had some good, reliable data. So what MAGIC did was it brought the Americans, the Europeans together and went back and saw all the 1,000 odd kids that were treated as germ cell tumors. And they gave us this. Now, what you see here is that all these gonadal germ cell tumors do quite well. Their predicted long-term disease-free survival was close to 100%. But there was a section that didn't do well. They were basically tumors that were not gonadal. So extragonadal tumors that were stage 2 to stage 3 in less than 11 years of age. Their predicted long-term disease-free was 91. Again, not bad, but if you were to see across the table, slightly lesser. And then again, less than 11 with a completely metastatic extragonadal came below that. And at the bottom of the list, you had children who were older than 11 years of age with extragonadal tumors did even poorer. So in extragonadal stage 4, more than 11 was the worst with its disease-free survival of only 40%. Now, there were some negative predictive values that are quite obvious from this table. One was definitely age. So age more than 11 conferred poor prognosis. And again, as per site, if it was extragonadal, they were slightly poorer. Now, coming to the staging of extragonadal germ cell tumors, the staging is the same across the board, whether it is ICMR, that is our consensus document, or the American or the Europeans. So the staging is pretty much like gonadal tumors itself. So stage 1 is when you have completely been able to resect this tumor when it is quite small. And they must have negative margins with really small nodes. And this has also been described that the nodes have to be less than 1 centimeters on imaging. Stage 2 is when there is some residual left behind. Or you've been able to do a gross total resection, but there was some contamination of field. But again, over here, the lymph nodes need to be negative. And all the peritoneal fluid that was collected also needs to be negative. Stage 3 is when you have a massive amount of disease left behind and you've only been able to do a biopsy. Again, the lymph nodes can be positive here or larger than 2 centimeters. And stage 4, quite standard, box standard, that if there was a distant met, it directly becomes stage 4. Now, coming to treatment protocols, as you would have heard a lot of chemotherapy jargon, it stays the same for an extragonadal tumor as well. But as you would see on the right and on the left, so the right is what the Americans follow, and the left is our ICMR consensus document. So extragonadal tumors are never low-risk tumors, which can be just treated with surgery alone. They will at least be intermediate risk. So all your stage 1 to 2, unlike, you'll never, it's very rare to find a stage 1 extragonadal tumor, but if it is an intermediate risk where you have to give some chemotherapy, some neoadjuvant chemotherapy, that is before you go in to operate. And all the others come in the high risk. As per ICMR, again, you would give 3 cycles of chemotherapy. So it is cisplatin, etoposide, bleomycin. And the high risk would get 4 cycles of chemotherapy, followed by surgery. Now, we've not gone into great detail about mediastinal or retroperitoneal because the treatment paradigm is similar to gonadal tumors. That is, first, you try to establish diagnosis. Once you've done that, to aid your surgery, you would try to shrink the tumor. But if it is completely dissected, then again, you go in for surgery. And then depending upon whether it is intermediate risk or high risk, you would give either 3 or 6 cycles of chemotherapy. Now, the other common site as compared to a mediastinal and retroperitoneal GCT, another common site is the intracranial component. CNS GCTs comprise about 3 to 5% of all brain tumors. Again, like any other germ cell tumor, there is a peak incidence in the second and the third decade of life. There is an unusually high male predominance. Again, CNS GCTs are always midline. So it is along its entire development and how it migrates. The commonest site to find a GCT would be your pineal gland. That is then followed by pituitary gland. And also your rest of the suprasellar areas, including the optic nerves. Very rarely, about 10%, you might have a bifocal presentation that Dr. Hiren has very beautifully shown on the MRI images, where you might have a tumor in both the pituitary and the pineal gland. An even rarer component is when you see it in the basal ganglia. Now, the signs and symptoms of these tumors obviously depend on the location. If this tumor is sitting in the pineal gland, there is a very distinct sign that you will see that is called as the Parinot syndrome. And the Parinot syndrome is when you have an upward gaze palsy. So the child will always be in a downward gaze with pupillary hyporeflexia, and there will be a convergent squint. Now, again, it can block your third ventricle, cause compression of aqueduct and obstructive hydrocephalus. If the tumor is sitting in the suprasellar area, so anywhere around the pineal gland, the most commonest symptom that they come with is polydipsia and polyuria, which tells you that there is an underlying diabetes insipidus. Very difficult to control hypernatremia. They come with delayed and precocious puberty, anorexia, mood swings. If involving the optic tract, the chiasm, you'll see some visual field effects and again, obstructive hydrocephalus. If it's in the basal ganglia, it's a very insidious in onset. So the symptoms might actually be cooking for about 1 to 4.5 years. And then they start to come with you with signs like hemiparesis, chorioathetosis, personality changes, ocular palsies, and speech disturbances. Now, as we have learned, even in intracranial germ cell tumors, you have the germinoma component and non-germinomatous component. So germinomas are more common, where generally the markers are negative, the tumor markers would be negative, or they might have a slightly high beta HCG component. Now, in the non-germinomatous component, you have choriocarcinomas, where the HCG will be abnormally high. Embryonal carcinomas, where on IHC, the immunohistochemistry CD30 will be positive. The yolk sac tumors, where AFP will be high, and the other components are your mature and immature teratomas. Now, when there is more than one component, you call it mixed non-germinomatous GCTs. Now, working up a brain tumor, or when you suspect a GCT, it is absolutely imperative to get a very good imaging of your brain along with the spine, because that is where it disseminates with great attention to your suprasellar regions. If you see a tumor sitting anywhere along the suprasellar components, you need to ask your radiologist to comment on the optic nerve and the chiasms as well. Needless to say, you would be doing tumor markers, as it would actually substitute tissue diagnosis. If you have a high AFP beta HCG, you can get away without doing a biopsy. Tumor markers also aid as a response to treatment. When you start treatment, it guides you whether what you're doing is right, wrong, working, not working. And before you decide it is refractory, you need to know the half-life of these tumor markers. So before you see any change in AFP after doing something about it, giving chemotherapy, it takes at least 5 days for AFP to cause a dent, and a beta HCG at least a day and a half or 2 days. Now, another way that tumor markers are absolutely helpful is that it also helps you with surveillance. So once the treatment is done, before you actually see, so MRI could be quite cumbersome, especially in children. So the easiest way you could do is these blood tests at 3 monthly, 6 monthly intervals, like how we would do surveillance for any tumors. Your whole workup is incomplete if you do not do a CSF. And when you do a CSF, you need to ask for cytology and tumor markers. Preferably, it should be a lumbar puncture. However, if there is a pineal tumor, there is a risk for herniation. Therefore, careful consideration, speaking to a neurosurgeon, working as a team, and then deciding how you're going to get the CSF. Because if there is obstructive hydrocephalus and if he's planning a surgery, then you might as well get your CSF that way. Now, it's important to know that CSF is generally more sensitive than serum tumor markers. Also, CSF positivity in terms of tumor markers is not equivalent to dissemination. For that, you need to do cytology. Now, role of biopsy is somewhat controversial, but it is preferred if markers do not indicate or it's not helping and all the markers are within normal limits. If you have a typical finding on the MRI, then again, you could possibly get away without doing a biopsy. Now, we've spoken that the commonest symptom that you can possibly see with an intracranial GCT is hydrocephalus, obstructive hydrocephalus. So there might be a stage where you do need to consider how do you relieve this hydrocephalus. And the procedure that would be preferable here would be a third ventriculostomy over a VP shunt. Now, coming to tumor markers, when you send a beta HCG and an alpha fetoprotein, how do you interpret it and how does it help you? So like we saw in the previous slide, a germinoma may actually have, it'll definitely have negative AFP, but the beta HCG may be low normal or it may be negative. Teratomas generally are not secreting. So both these tumor markers will be negative. Choriocarcinoma will have an abnormally high beta HCG. A yolk sac tumor would have a abnormally high alpha fetoprotein. And again, embryonal carcinoma might actually secrete both or have a low normal values of these tumor markers. Now, imaging, Dr. Hiren has already spoken about. So a germinoma has a typical finding on the MRI. The first image that you see is when the tumor is sitting in the suprasellar area. And what is common to all these three, these are homogeneously enhancing, contrast enhancing, and they're quite isodense on T2. The third image is your bifocal germ cell tumor, where you see a tumor sitting both in your pineal and suprasellar area. As compared to a germinoma, a non-germinomatous GCT is actually non-homogeneously enhancing, and there will be some areas that are dark and some areas are enhancing. And a teratoma could actually, again, because of the components of fat, they're non-homogeneous and they're quite large and dark on B2. Now, incidence, again, an uncommon brain tumor, but again, in terms of germ cell tumor, it is one of the commonest sites. Unusually high incidence in Japan and in boys. So there is some genetic link that is suspected. As you see that it's basically your first and second decade of life is when you start to see a peak. Another syndrome that we must be aware of is that of growing teratoma syndrome, where you will actually have the tumor growing in size, but actually the tumor markers are going down. These have some typical appearances on imaging. They show a honeycomb appearance, which basically tell you that it's multicystic. They're more often than not, they're all a component of non-germinomatous GCTs. These are generally not responsive to chemo, and you have to ask your surgeon to go in and operate. Now, Japan is where you have the highest incidence, and Japan has a way of categorizing these tumors as good risk, intermediate risk, and poor risk. When you have a pure germinoma or a mature teratoma, they call it good risk, and intermediate risk is when you have slightly high beta HCG germinomas and immature teratomas, and all the others are poor risk. However, in Europe and in the US, it's slightly different. These tumors are either grouped as germinomas or non-germinomas based on the tumor markers. Now, coming to treatment of non-germinomatous GCT. So this was one of the first trial that incorporated both chemotherapy and radiotherapy. Now, unlike your mediastinal, your retroperitoneal, gonadal, which are quite chemosensitive, and the whole treatment begins and ends with chemotherapy and surgery. Here you need a combination of a lot of other modalities of management. And the chemotherapy, again, etoposide is common, and a platinum forms the backbone of the chemotherapy. But here, instead of bleomycin, we do ifosfamide, as it needs to cross the blood-brain barrier. So they did chemotherapy followed by radiotherapy for localized tumors. And for the tumors that were metastatic, they did a whole craniospinal irradiation. And the conclusions that came out of this trial was that, one, what you see on the right, that a high AFP is associated with poor prognosis, and also any residual disease at the end of treatment conferred poor prognosis. Hence, surgery is recommended if there is incomplete response to chemotherapy, and focal radiation is actually enough for a localized tumor. Progression-free survival was poorer for metastatic disease. Now, when the Americans speak a different language, so they did this study called ACNS 0122, where they did 6 cycles of chemotherapy. So this is one brain tumor where you're not going to jump the gun of operating on it first, because it can be highly morbid. So you might actually do neoadjuvant. Brain tumors generally do not have neoadjuvant chemotherapy, but this is one condition where you start with chemotherapy. So they did 6 cycles of chemotherapy. Then they evaluated. If there was if they went in complete remission, you take them through radiation. If there was less than complete remission, then you ask your surgeon if he could do another surgery. And if it was clean, then they would then take through radiation. If there was any poor response, then they go through high-dose chemotherapy followed by stem cell rescue. So autologous transplant and then radiation. And with this approach, the outcome was quite superior to the tune of 92 to 98%. Now, we spoke about non-germinomatous DCTs, coming to germinoma, which are extremely chemosensitive and radiosensitive tumors. And unlike non-germinomatous, the outcome for germinoma is quite superior. However, again, only with radiation, it was poor, and also just chemotherapy gave you an overall survival of 84% and a 5-year overall survival of 68%, which was not acceptable. Hence, again, PSYOP GCT combined chemo and radiation, and the event-free survival, that means without any relapse, children who were alive at 5 years, was almost 100%. Even the Europeans demonstrated with their study in France, and Japan says the same. So this was the scheme where they did 4 cycles of chemotherapy followed by radiation. However, there were 7 around the ventricles. So the current standard approach is that they actually radiate the whole ventricle instead of just the tumor site. So to summarize, intracranial GCTs are of 2 types. You have germinomas, which are more common, and non-germinomatous, which is comprised of 1/3 of the intracranial GCTs. Germinomas, the survival is quite superior, almost more than 90%, almost close to 100%, extremely radiosensitive. And you would treat it with localized radiotherapy where you're covering the ventricles. Non-germinomatous, as compared to germinomas, the outcome is 70%, where again you need chemotherapy and radiation. So you would do induction chemotherapy followed by radiation. So GCTs are actually a mixed bag of tumors. Tumor marker elevation is sufficient for diagnosis, and if you do have that, you do not need a biopsy. You definitely need a combined treatment approach to give a superior outcome, and that would comprise of chemotherapy and focal radiation. Germinomas are generally AFP negative, and beta HCG may or may not be high. Again, if you have tumor markers, a biopsy is generally recommended for a germinoma unless, like we showed in the MRI, that you have a bifocal presentation, both in the suprasellar and in the pineal region. This is an extremely chemo and radiosensitive tumor, and the outcome is as good as 100% here. And it is so good that now we are thinking of scaling down the treatment in terms of chemotherapy and radiation. Thank you. I'd like Dr. Kriti to talk about sacrococcygeal tumor.
Sorry for the delay, and I'd like to thank all my previous speakers who have made my life more simpler by discussing everything. And so now we come to the sacrococcygeal teratomas. It's an extragonadal germ cell tumor which Kriti touched upon, and it develops during the fetal and neonatal periods. And it is the most common type 1 germ cell tumor, in which teratoma and yolk sac tumors, they arise from the extragonadal cells. It is a tumor which develops from the sacrum and coccyx, and it protrudes not only outwards but inwards into the pelvic cavity as well. It's a rare disease with an incidence of 1 in 20,000 to 40,000 live births. There's a clear female predominance with the ratio being 3:1 to 4:1 in females compared to males. It's sporadic, there is no definite familial tendency, but it is seen to exist in 10 to 15% of twin gestations. It can be associated with congenital anomalies like hydronephrosis. Usually the urogenital system is affected, and so there may be hydronephrosis. There is a rare association with the Curarino triad. And what is this triad? This triad has sacral bony defects, anorectal anomalies, and a presacral mass. And approximately 40% of these presacral masses are teratomas. The Curarino triad is an autosomal dominant syndrome, and it's linked to mutations in the HLX-B9 gene. Now, when we talk of the pathogenesis, this we have heard right from the beginning of this session that the primordial germ cells, if they don't migrate properly, and instead of reaching the gonadal ridges, they pass through the hindgut, and if they get mutate over there, then can give rise to a sacrococcygeal teratoma. There is another theory also that these tumors, they correspond to the region, the sacrococcygeal region. It corresponds to the primitive streak and the Henson's node in early embryonic development. And if there are some residual totipotent stem cells in the Henson's node, they can develop into a teratoma or a yolk sac tumor. And these are the two most common pathologies which are encountered in sacrococcygeal teratomas. Migrating primordial germ cells depend on the KIT ligand for their signaling and survival. So if these are reprogrammed to attain pluripotency, ban abnormal microenvironment and become embryonic stem cells, they survive without the KIT pathway, and that's how they form the teratomas. And the next thing is they evade apoptosis also. And the anti-apoptosis gene, BAK1 gene, is associated with these sacrococcygeal teratomas. So this is the pathogenesis of the sacrococcygeal teratomas, that they bypass the KIT ligand pathway, and they also bypass the BAK1 gene, which helps them in formation of the teratomas. Now, these teratomas are composed of all three germ cell layers, and so they have a solid cystic and a mixed component. And unlike the teratomas in other locations, what differs from them is that they don't have a capsule or a pseudocapsule, and that's a very difficult thing to achieve a complete remission, which Rasik sir will be talking about. And these teratomas can include mature, immature, and malignant elements, which we have heard time and again. Now, what are these mature teratomas? They have fully differentiated tissues, and these tissues may be small islands of cells or fully functional glandular tissues, such as the pancreatic cells or the Langerhans cells, sebaceous glands. There may be bone hair teeth, and these are usually harmless. The next one is the immature teratomas. Even if they have a small component of the embryonal components or incompletely differentiated tissue structures, then this gives them immaturity. There may be primitive neuroectodermal features such as primitive neural tubes, immature rosettes. And this is graded. The immature teratomas are graded according to the Gonzalez grading system, where if the grade 3 is the tumors, the teratomas which are more than 50% of immature tissue, whereas grade 1 is less than 10% and grade 2 is anywhere between 10 to 50% of immature tissue. The last is the malignant teratomas. 11 to 13% of these postnatal sacrococcygeal teratomas are malignant. And the most common element is the yolk sac component, which gives rise to high AFP levels, which we have been hearing. Even embryonal carcinoma and PNETs can be seen in these malignant components. So it is very important that we monitor with AFP levels and beta HCG levels, because if we take a biopsy, the components may not represent the complete element, malignant element, and we may miss on this. So it's very, very important that we monitor these patients with alpha fetoprotein and beta HCG. Now, what we see is that most of these, around 50%, are diagnosed in utero during routine ultrasound examination. And if we diagnose them prior to 30 weeks, then especially it is spelling a disaster, because the earlier you pick these up, they are usually large and hazardous. And then there is always a problem of fetal dystocia, rupture of tumors, massive hemorrhage, because if they are hypovascular tumors, they can cause complications during labor. Now, when these tumors are large, they can cause other symptoms such as constipation, urinary retention, and an abdominal MRI is indicated for all patients to assess the extent of the tumor. Always, when you have a sacrococcygeal teratoma, you should look for associated malformations such as a hip dislocation, spinal dysraphism, cardiac anomalies. And if the child has lower limb weakness or hypotonia, then either an intradural spinal extension of the tumor has happened or there is associated spinal dysraphism. Neonates with a large sacrococcygeal teratoma also can have a consumptive coagulopathy, thrombocytopenia, DIC, and profuse hemorrhage. And therefore, the platelet count and coagulation profile should be checked in these children. So in neonates that present with a sacrococcygeal teratoma, very important to have a CBC to look at the platelet count, the coagulation profile, along with the tumor markers like alpha-fetoprotein and beta-HCG. Because as we heard, that yolk sac tumors can produce high levels of AFP. Now, these are classified according to the Altman classification, which divides them into 4 types. The commonest is the type 1, and the least common is the type 4. The 45% present with the type 1, where the tumor is predominantly external. In type 2, a significant portion, the tumor is external, but a significant intrapelvic portion is also present. Type 3 tumors are predominant intrapelvic, and in type 4 presacral tumors, there is no external component. In the type 2 to 4 tumors, which are predominant internals, there is a mass effect which happens on the intrapelvic organs. And so these children may present with severe problems such as constipation, fecal incontinence, neurogenic bladder, urinary incontinence. And the type 3 tumors require for resection, which Sir will be talking about surgical wise. So when you look at this pictorial representation, you can see that the type 1 tumor, that is the A1, most of it is external compared to the B, where there is an external and an internal component. In the type C, most of it is intrapelvic, and the type 4, there is no external component at all. So this is how the Altman has divided and staged these tumors. This is not the only tumor that happens in the sacrococcygeal area, and there are other tumors like myelocystis, terminal myelocele, and terminal myelocystocele. How do you differentiate with the sacrococcygeal teratomas is that the sacrococcygeal teratomas are located more caudally, whereas the rest of them are on a higher location. And the other tumors may have a hair or a hemangioma over the mass, or they may have accompanying neurological deficits, such as lower extremity weakness, bladder dysfunction. Prenatal detection, usually they are detected during the 2nd trimester during routine sonography. Some have been detected even during the 1st trimester. And most of them are Altman type 1 or 2, where there is a major external component and not an intrapelvic component. A sonography should also, apart from the mass, look at whether there is a bladder outlet obstruction, hydronephrosis, there is rectal stenosis, atresia, or cardiomegaly. A fetal MRI is recommended wherever it's available, and the MRI more accurately characterizes the intrapelvic and abdominal extent of the tumor. Solid portions of the tumor should be, so when we talk of sacrococcygeal teratomas, they can be either solid or they can be cystic, and the solid components are more dangerous compared to the cystic components. Especially, they have a higher vascular flow, and that causes a vascular steal phenomenon, which places the fetus at increased risk of hydropic changes. If it is if it's a large lesion more than 10 centimeter, especially vascular ones, they are associated with a higher perinatal mortality rate. But if it's a cystic lesion, even if it's large, they display a slow growth and have a more favorable outcome. The amniotic fluid volume and the placental thickness should also be evaluated, as polyhydramnios and placental thickening are markers for hydrops. follow it. So depending on whether on the scan, first scan, whether it is solid or cystic, the subsequent scans should be planned. If it is a cystic mass, then you can do it as infrequently as every 2 weeks a scan. Or if it's a small mass, then you can again do it every 2 weekly. But if you think it's a solid mass, it's more vascular, then you may even have to scan the mother every twice in a week. Fetal echo is recommended in fetuses with predominantly solid or vascular tumors. And echo is used to identify a high output cardiac state, which precedes the onset of hydrops. So the radiologists have a way of prognosticating these tumors, where they say the tumor volume to the fetal weight ratio. If it's more than 0.1 on ultrasound before 24 weeks, it is a poor prognostic sign. And between 24 to 30 weeks, if the TFR is more than equal to 0.11, then it's again associated with a 6-fold increased risk. The type of Altman classification, whether it's type 1, 2 versus 3 or 4, had no statistic significance. So even if you have a type 4 tumor, it is not a poor outcome risk factor. Perinatally, these children have a very high mortality rate of 25 to 50%, which includes pregnancy termination, intrauterine death, neonatal death. And the potential perinatal complications are preterm labor, spontaneous tumor hemorrhage or rupture, and maternal mirror syndrome, in which exactly like fetal hydrops, the mother also can have maternal edema and hypertension. For some high-risk fetuses, in utero fetal surgery is done in certain area, in certain centers, specialized centers abroad. But the contraindication to do open fetal surgery would be type 3 or 4 Altman type tumors, severe placentamegaly, cervical shortening, and maternal medical issues. Minimally invasive in utero approaches are also being tried abroad, like laser ablation, radiofrequency ablation, bladder drainage for obstructive uropathy. But then, what is the outcome of all this? For perinatal survival, with open fetal procedures is around 50%, so they are still losing 50% of the children. And for minimally laser ablation and minimally invasive procedures, the perinatal survival is 44%. And the cohort age, mean gestational age at the birth for the entire cohort was 30 weeks. So, I'm sorry, my slides have stopped moving. So in selected high-risk fetuses, even an early delivery and ex utero surgery is done after 27 to 28 weeks. Whereas with low-risk fetuses, they can be delivered by C-section after 36 weeks. And small tumors with less than 5 centimeters can be delivered vaginally too. Postnatal evaluation is if you have not performed the fetal MRI, then you can, as a child is born, you can do an MRI of the primary site to assess the extent of internal tumor. And you can further stage by doing a CT chest and a bone scan. As we know that AFP and beta HCG levels should be assessed. The surgical resection, as Sir would be talking in great about this, but surgical resection should basically remove the entire coccyx. Without the removal of the coccyx, the chance of recurrence is definitely there. Now, when we talk of the post-operative therapy for benign sacrococcygeal teratomas, both everywhere, UK, Germany, and American have agreed that surgical resection for benign sacrococcygeal teratomas is the ultimate treatment. And even if it's an immature teratoma, they have gone away with chemotherapy and just do observation. But if there are malignant elements, then the Cox staging, which is used for extragonadal germ cell tumors, comes into play, which Kriti has explained beautifully. She has gone through all this, so I will not repeat what she's already said. So when we have the stage 1 malignant sacrococcygeal tumors with malignant elements, the previous trial used to give 3-drug chemotherapy BEP, but now the active trial in the stage 1 extragonadal germ cell tumors, they are saying you to observe without immediate chemotherapy. For stage 2, a BEP or a BEJ based chemotherapy can be considered. For stage 3 and 4, Can you please mute yourselves? For stage 3 and 4, neoadjuvant chemotherapy has been advised. And if with neoadjuvant chemotherapy, the event-free survival, both in the American and the UK group have exceeded 80%, the event-free and the overall survivals. But in the same groups, the stage 3 and 4 malignant GCTs, the event-free survival and overall survival dropped to 49% if they were subjected to upfront surgery. So once they are operated upon, surveillance and they've undergone chemotherapy, surveillance is very, very important because these tumors can relapse up to 5 years after the treatment. And so a clinical examination at 3 to 6 months interval is very, very mandatory. And AFP and LDH level monitoring every monthly for the first year and then every 2 to 6 monthly in the subsequent years is required. Post-surgery and MRI and the chest radiograph at 3 and 12 months after resection is what is needed for evaluating. We know that these tumors can recur and the mature teratomas have a 10% chance of recurrence and the immature ones have a 20% chance of recurrence. Incomplete resection or a malignant histology are the most important risk factors for recurrence. And the majority of the recurrence occur in the first 3 years after treatment, but can occur later also. And the first 5 years are the most crucial for these. Now, that's why what was observed is that the AFP was elevated in 75% of these patients with recurrent sacrococcygeal teratomas. And so the importance of monitoring these tumors with a serial AFP measurement is very, very important. But not to forget that a physical examination along with a digital rectal examination is also mandatory for these children. MRI or CT should be performed if you find elevated AFP levels or your clinical examination suggests that something is going wrong. Now, when we looked at the treatment of recurrence, the COX study has used paclitaxel, ifosfamide, vinblastine for these children. And in younger children, this combination has shown a very good response. But in the adolescents, the response has not been different from the other chemotherapy regimens that have been used. So, to avoid recurrence, a timely examination, follow-up, monthly AFPs, digital rectal examination is very, very important. I'd like to summarize by saying that sacrococcygeal tumors, teratomas are usually detected in the second trimester, at times detected in the first trimester. Ointment type 4 usually have a malignant component. The type 1 sacrococcygeal teratomas with malignant elements are just being observed post-surgery, and so are the immature teratomas. The stage 2 need platinum-based chemotherapy post-surgery, and the stage 3 and 4 need upfront chemotherapy before exploring them for surgery. Thank you. I would now ask Dr. Monica Bhagat, our pediatric surgeon, to give her talk.
Good evening, everyone. I'll be talking about surgical aspects of gonadal germ cell tumors. I think most of the things have been covered, so I'll skip initial few slides. It is seen that ovarian tumors are mostly seen in girls more than 10 years of age, and for boys it is biphasic. So we have children less than around 4 years of age, and then post-pubertal we have testicular tumors which are seen. I'll be focusing on gonadal tumors only, so I'll skip other things. So 50%, 42, around 42% gonadal tumors are seen in pediatric age group, which is while in adults there are 98%. These are certain risk factors and genetics involved. So understanding testes, we need to do the surgery because otherwise the chances of having developing a testicular tumor is increased. The other XY syndromes, which are Klinefelter syndromes, Vyas syndromes, and Turner syndrome, where are the high chances of them getting dysgerminoma later on. So they need basically bilateral gonads have to come out in these patients. So everybody is told you about tumor markers. They are really important. So first thing is, if we have a tumor marker which is raised, a biopsy has to be avoided because we have a diagnosis using tumor markers. So biopsy can be avoided. So it helps us with diagnosis, assessment of chemotherapy and other treatment, and surveillance. Coming to the treatment, surgery, chemotherapy, and radiotherapy has been discussed. I'll be focusing on the surgical part. Surgical is basically having a diagnosis when, especially the tumor markers are not raised, having doing a proper staging, and thus helping us in treatment planning. So starting with ovarian germ cell tumors, they present with abdominal mass or pain. Sometimes they present in emergency with torsion or rupture of the tumor. There are 10 to 15% where bilateral disease are seen, especially in dysgerminomas. For the ovarian tumors, the open surgical resection is the ideal choice. Any attempt to aspirate the fluid is considered as tumor spill, and the stage is increased. Cytology has to be done. So there is no proper RPLND, but any enlarged node has to be sampled because it helps in staging and deciding what chemotherapy is to be given. Any peritoneal or omental deposits have to be sampled. Contralateral biopsy is just seen if there is any suspicion of any disease, it has to be biopsied. For bilateral diseases, we have to go by a conservative approach. If the markers are raised, then we can give chemotherapy, and there is a second look surgery which can be done. For DSDs, we have to do bilateral tumors, they have to be removed. Bilateral gonads have to be removed. So I think staging has already been covered. So MAGIC trial is having a stage 1 disease where we do after having a proper, the thing is proper staging has to be done, and it means removing the node, also doing a sampling of the node and cytology. So the first stage 1 and stage 1 patients, chemotherapy can be totally avoided if staging is done properly. For the testicular germ cell tumors, it presents as painless total mass, or it can present as an acute trauma torsion where parents notice that there's a slightly enlarged size of the testes. So the ideal choice of doing removing a testicular tumor is inguinal route. There's the initial control of the vessels has to be taken, and it should be a high ligation of the cord structure. Then any transscrotal violation is to be avoided. If it is done, then it is considered if the stage is increased, so it is stage 2. Cord or stump revision is done if the margins are positive, so it is stage 2. Any retroperitoneal lymph node dissection is done if there is a gross disease which is remaining even after chemotherapy. So similar to the stage 1 in the ovaries, the testicular stage 1 tumor can be observed after removing these testes. The tumor markers have to be followed up for initial 3 months regularly to see whether the trend is in the decreasing side. Risk stratification has already been covered, so I'm just skipping it. So there is role of organ preserving surgery in both testicular and ovarian tumors. Benign, the tumor markers should be negative in these situations, and imaging should suggest a benign thing or a teratoma. Then only the organ preservation surgeries can be done. So teratoma is the common thing where the imaging is very characteristic, and we can do organ sparing surgeries. Others are like gonadal stromal tumors where testicular sparing surgeries can be attempted. Laparoscopic surgery for ovarian tumors are generally not recommended. First thing is the tumors are mostly very large, and ovary should come given to the pathologist intact so that they can completely study it before it is bisected. The other thing is if it is a small tumor and there's a chance of doing a partial dissection, which is possible if we are doing it in the open approach because we have an adequate exposure, and when we can isolate the ovary and do this ovarian preservation surgery. So if there are some European states where they do give a suprapubic incision. With that incision, we are not able to basically examine liver and peritoneal in the superior side, because normally they give midline. Normally it is recommended to give midline midline incision. So when it is a suprapubic peninsula incision, sometimes laparoscopy is used to evaluate peritoneal surface and liver surface. To conclude, germ cell tumors have good outcomes. Adequate surgical staging is important, and so that it helps us in planning the treatment. And organ preservation is possible in selected cases. I'll invite Dr. Rasik sir to give the further surgical talks as per the sites. Thank you.
Thank you, Monica. So I'll show you one video of dermoid ovary, dermoid cyst of ovary, which will also fall into germ cell tumor, and then we will discuss about germ cell tumor at the other sides. Windows. Where will be pen drive? Yeah, so
And I will run this PC, my PC or this PC. Nothing right. Hello?
presentation to video not to anyone.
करता मेरी यार
Hmm?
सनाच्या झाडात
Hmm.
शेवट.
So
शेवट. This PC मध्ये
that's yeah, but which one will be this? Anyway, let me just show my presentation. And then you will see if we can open the video, we'll open it. So I'm going to touch upon only, can you see it? Okay. I am going to touch upon the standard principles of management of germ cell tumor at non-gonadal sites. So basically sacrococcygeal, all of this is covered up to certain extent. We will just go through some of the important points in surgical aspects. So sacrococcygeal teratoma, the types has been already described. Type 1 is majority part is external, some part is type 2 is inside, outside both. Type 3 will be internal and smaller external component. इसमें वीडियो ओपन करता है कहाँ से so a biomedical person is here to help. let's start with the presentation again. Yeah. So it has been converted from key to PowerPoint. So some of the things are missing on the slide, but let's see whatever we can. So you know there are 4 types. Why we need to know the types? Because the surgery will be accordingly. So if it is type 4, we may not be able to do it from the perineal aspect. Type 3 also, one may be able to do it or not depending upon the internal component. And then further classification was whether it is solid, cystic or mixed. If it is solid, again, it may not be possible if it is particularly type 3, 4, doing it from the perineal site, and we may have to do abdominal aspect first and then do perineal aspect. So this is the reason why we need to understand how the things are. Now, some part of the antenatal detection was covered. So in the management side, what is important basically, this is for the diagnosis which has been covered. Postnatal treatment is surgical excision along with the coccyx that has been specified multiple times. Antenatal anomaly scan, when we do it, one needs to check the size of the tumor. If it is small, we can it is a good prognosis. Large tumor obviously will have little poor prognosis because it can lead to polyhydramnios with hydros fetalis. The content, if it is cystic, it is better, less likely to develop hydrops. If it is solid, large tumor, more likely to develop hydrops. Fetal echocardiography has been mentioned by Dr. Priti Mehta. Maternal mirror syndrome again has been mentioned by her. So we will not go into the details. So, yeah, important thing, if it is, the tumor is large, then we need to do C-section. And the second important point is the delivery should be done where pediatric surgical expertise is available. Frequent monitoring of large and solid tumor again was emphasized by Dr. Priti Mehta. Now, this is important for all of us to remember. If it is before 32 weeks, if the fetus is developing heart failure, then one may do fetal intervention. If it is beyond 32 weeks, then early delivery with intensive management after birth. So 32 weeks is like a benchmark whether you want to do fetal intervention versus early delivery and postnatal management. Then in fetal intervention, there are different things which can be done again, which was told by Dr. Priti Mehta. One can do minimal invasive surgery to disrupt the blood supply of the tumor using RFA or laser, or one may do open fetal surgery. Then mode of delivery in sacrococcygeal teratoma, C-section with excision of sacrococcygeal teratoma after that, or one can do exit procedure where if we are worried about postnatally about oxygenation and other things, then one can do ex utero intrapartum where the oxygenation is continued using umbilical cord. Sacrococcygeal teratoma is excised and then the umbilical cord is divided. So for this, you need a lot of coordination between surgeon, gynecologists, radiologists, etc. But it can be done, and a lot of centers have done multiple of these surgeries. This is one of the patients which we recently operated, where there was huge component going into the abdomen almost at the level of L2, L3. So looking at this, it appears that we may not be able to do it through the perineal route, but because it was cystic, we could manage it to do through the perineal route by decompression of the cyst. Otherwise, one will have to do abdominal component and then do the perineal component. Now, the important part is, again, you can see here it is cystic. This is the head end on this side. Anus is over here. Now, this is how, like, this is the Mercedes-Benz incision, sort of. This is the incision we take. And then there is a continuation of incision on the back side of the tumor. So this is like that, and then on the back side. And at the end of excision, this is what was the picture. Now, technically, as it was told earlier, that this tumor is extending into the abdomen. So it will be compressing on the intra-abdominal structure, including urethra, bladder in male child. In female, it will compress onto the or closely related to vagina, uterus, ureters, and one has to be careful. If we are not careful, we can damage all these structures. More commonly, the problem is with the musculature of perineal area and the nerve supply of the bladder and bowel. So we need to remain close to the tumor, but we need to excise it completely. If we don't excise it completely, it can recur. We need to remove the coccyx also. And generally what we do is the blood supply is from the median sacral artery, and one needs to control that first, otherwise there may be a significant bleeding from the tumor. Particularly if it is solid tumor, it is likely to bleed. Now there are ways you can decrease the bleeding. Some people do abdominal part first, even if it is most of the tumor is outside, to divide the median sacral artery, and that can be done by minimally invasive technique. We have not done any of them, but it has been described in the literature. So to control the bleeding, one may do division of median sacral artery from the minimal excess technique, and then you go to the perineal route and excise. This was in the post-op period. At the end of 3 months, you can see that you can't see a lot of scar at this point. And if we separate it, one can see the scar. We did rectal examination, it was all right. Because for early recurrence, it is better to do rectal examination in all your patients, along with serum alpha-fetoprotein, and periodic sonography should be carried out. The complications of surgery will include neurogenic bladder, incontinence for stool. It can be cosmetically disfiguring. Initially, we think it is all right, but in long run, for the good life, all these small factors are also important. It can be extending into the spinal cord, spinal canal, and we may have to take help of the neurosurgeon and excise it. Bleeding, infection, recurrence, malignancy, all this can happen. Then the second part is the retroperitoneal teratoma. Again, the principles is en bloc surgical resection is the main treatment. Usually it is benign, but many of them can be malignant. So you need to excise it completely. Close follow-up after surgery is required. Risk of malignant transformation is 3 to 6%. Common site is above the left kidney, and it can grow to the enormous size before the detection. The principles include, again, complete excision is the aim of surgery, preserving important structures. Recurrence depends upon the presence of immature cells. Large upper abdominal transverse incision is important. Unless we have a good exposure, we will not be able to excise it completely. Self-retaining retractors will help in exposure of the areas. Thompson, Book, Walter, etc. helps us. There is a risk of malignant transformation of teratomas, which may be the cause of relapse if the tumor is not excised completely. Late relapse is defined as recurrence after 2 years. And this malignant variant responds poorly to the adjuvant treatment, so it is better to diagnose them early by periodic checkups. Some of this part is missing here because of that conversion. So as we told, many of them are very large. They are very closely related to important structures, and to excise it completely, we need to study it well by CT, MRI, and if we can do 3D reconstruction, then it helps in planning of surgery. And if we do that 3D reconstruction, it gives very good delineation of normal anatomy. There is decrease in hemorrhage, decrease in injury to surrounding important structures, and one can excise it completely. Reconstruction of vessels can be done and shortens the operative time. Then surgical risk factors for retroperitoneal trauma. This is one of the paper which says that the complication, the incidence of complications. So almost 41% of the patients had perioperative complications, including nephrectomy in 4 patients, adrenal gland excision in one of the patients, then involvement of artery, vein, and organs. All this is quite common in case of retroperitoneal teratoma, and one has to be careful while resecting all these tumors. Then the mediastinal teratoma, again, by the time they are diagnosed, many of them are very large, related to important structures like superior vena cava, brachiocephaly, aorta, etc., right atrium, pericardium, phrenic nerve. So all this needs to be studied well, planned before the surgery. Again, the complete excision is the mainstay in the treatment. The exposure is the vital or plays the great role. Availability of pediatric cardiac surgeon and placing the patient on bypass. These are mandatory for the large mediastinal teratoma. So depending upon the location, as it was discussed earlier, it is more commonly, it is in the anterior mediastinum, but rarely it can occur even in the posterior mediastinum. It can grow to the huge size. Incision can be sternotomy. It can be clamp cell like this one or trapdoor like this one. Because unless you have a very good exposure, we will not be able to excise it completely. The small tumor can be done by thoracoscopic approach. Now, if it is done antenatally detected mediastinal teratoma, then one has to keep under observation like sacrococcygeal teratoma. And if there is any chance of development of hydrophytalis, then one may plan fetal intervention where available before 32 weeks, and after 32 weeks should be early delivery. And in some of the patient, exit procedure can help. Similarly, in cervical teratoma, many of them can be diagnosed antenatally. Management again by multidisciplinary team, which will include, this is particularly when they are diagnosed antenatally, when they are very large. Postnatally, we may not be able to have a good access to the airway, and that can be the problem. Now, how you can detect this? So, lung can be hyperinflated because of the pressure on trachea. Pressure on esophagus will give rise to empty stomach and polyhydramnios. And then the ears can be displaced upwards. The amniotic fluid will be large. They can develop hydrophytalis, particularly when they are solid. And again, the important thing is complete excision of the large disfiguring mass. And that is not impossible. It is quite possible. It can be done. So again, when they are large, one has to do something like exit procedure, establish the airway, and then take the patient for surgery. Debulking followed by establishment of the airway can be done. And many of them will need prolonged tracheostomy because of the tracheomalacia. The trachea is soft and it will collapse. So prolonged tracheostomy and its good care is required. This is one of the paper which was published on antenatally detected large cervical teratoma. Of that, out of 9 patients, they could establish airway in 8 patients, 2 by endotracheal tube and 6 by tracheostomy. This is with the exit procedure. If there was no exit procedure, probably these kids would not have survived. And in one case, they were not able to establish the airway. So these are general guidelines and principles of management of GCT non-gonadal side. Now we will see if there are any particular questions. I will request Dr. Kurkure to answer them. Or if there are any particular questions to anybody, we'll just go through that. As of now, we'll check most of the things are.
registration.
Yeah, registration. Slides moving, this was it.
While Dr. Rasik Shah is
Yeah, you
looking
can-
at the chats, I will just conclude in meantime the session. Thank you all for joining us on this masterclass on the occasion of the International Childhood Cancer Day. And though germ cell tumors are rare, they are highly curable. And the very presentation that they have from head to toe makes it very imperative that all of us, as a pediatricians, pediatric surgeons, are aware of their disposition as to where to suspect and when to suspect, because timely intervention can really give good results, even in stage 3 and 4 diseases, particularly restricted to gonads. There is very good outcome. So the outcomes are good. It is how we detect and take care of them in a timely fashion which matters. And if they are detected early, then we can um, de-escalate the therapy and achieve same results with better quality without much treatment post-surgery. Also, I would like to stress that any abnormal presentations in the midline, one can do tumor markers easily. There is nothing to lose because it's a non-invasive investigation. While we are doing many other blood investigations, we can easily ask for the tumor markers and can save many lives. That is one message. And secondly, what I would say is that when it is a resectable tumor, like ovarian or a testicular, glaring at you, still surgery at that stage should be by the principles, oncological principles, as if it is going to be malignant. And if we do that, and for example, in testicular tumors, if we don't have a transportal approach, or we don't consider that as always a hernia and tackle them accordingly, I think that will be better in a long run, because we do come across many of the situations where common things are, of course, suspected, but if there is a slightest doubt that this could be tumor and it is resectable, then it is better to err on the higher side and approach it with the oncological principles so that we are not lost any ground. So these are the few key messages, and keep it always keep it tuned. We'll be again back to you in September, which is again observed as a childhood cancer month, and we will try to do some other academic event then. Till then, Dr. Rasik Shah, you want to show them? Okay.
I had a video of dermoid, ovarian dermoid done laparoscopically, but I think we'll skip that. It is already 5:41. Thank you once again for attending today's webinar on germ cell tumor. See you soon with the next master class, which will be on 3rd Wednesday of March, that is 20th March. Topic will be finalized in next few days and will be communicated to you all. Thank you very much.